Hello, everyone, and thanks so much for joining us today. My name's Alexis May. I'm Director of Content for AI Med. Just a couple of housekeeping points before we get started. All sessions today will take place here on the main stage. To the right of this panel, you will see a chat function. We encourage you very much to use that. Feel free to submit any questions, comments, and we'll endeavour to answer as many as we can during the day. If you do have any issues with the platform, my excellent colleague Andrew will be able to help. Best way to contact him is by email at aj@ai-med.io. As you hopefully know, AI Med is the only clinician-led movement dedicated to artificial intelligence in health and care, connecting and educating clinicians, healthcare executives, and industry to inspire action and drive forward the deployment of AI. To complement meetings like today, we've developed the AI Med Connect platform to facilitate communication and collaboration between the key stakeholders involved in the implementation of AI in healthcare. If you want to check that out, the simplest way to sign up for this is to search for AI Med on your app store. We will share some further information later. Thanks so much for listening. I'm going to hand over to Dr. Chang now to get things started. We look forward to hearing from all of you and to a great day. Thank you.
Good morning and good afternoon or good evening, everybody, from wherever you are. Welcome to a special AI Med program that's designed for healthcare executives and leaders. Particularly excited because we've been planning this day for quite some time to address all the issues, and the timing is absolutely perfect because we're all in the middle of the COVID-19 pandemic. So artificial intelligence, is it irrational hype or paradigm shift? I also want to thank several organizations that form an alliance for this webinar, the Healthcare Executives of Southern California. So for those of you who belong to that, thank you very much for participating, and thank you to Anne and David for sponsoring that with us. Also want to say a special thank you to Dr. Arlen Myers of Society of Physician Entrepreneurs, and also Dr. David Livian for the American College of Healthcare Trustees. So you see that we have many organizations part of today's program. And last but not least, the Chalk Children's Medical Intelligence and Innovation Institute that I'm the very proud director of. So we're in the middle of the pandemic, and I think I want to pay a special tribute to all of us healthcare workers and on the front lines, as well as right behind the front line during this very difficult time. So thank you very much for being part of today, and hopefully today will be an inspiration for you to go back to work and make some serious changes in healthcare that we're so in need of. So why artificial intelligence, and what is it and how is it relevant? So on the clinical side, I think there's tremendous information overload. And I think all of you are in decision-making roles. So I think it's particularly important to realize that the medical information volume has increased exponentially. So the doubling time of medical knowledge used to be years, and now it's measured in months. And if you look at the COVID-19 pandemic, this is as of 1 a.m. this morning. If you go on PubMed, there are now close to 60,000 publications since the beginning of this year. So how is anyone able to cope with this amount of information? I think one of the first important takeaways, and speaking of takeaways, I'll be busy taking notes throughout the 5 hours that we have together, and that list of takeaways will be passed on to you. So I think we start with data. And I think when I was asked about artificial intelligence and the pandemic and how has AI helped or not helped, I think we kind of magnified the problem of the foundational layer of what I call the data intelligence continuum. And that means that data, being the foundation, has had challenges. And so in order to get good dividends from artificial intelligence, which is on top of this pyramid, right under wisdom, which only humans can provide, we really need the foundation layer to be very, very robust. So, and because from data, we get information, which is sort of data in context. And then from information, we get knowledge, which is information that you can apply and make change. And intelligence is sort of on top of this, and it's basically being able to make predictions. So if you were to define very quickly what intelligence is having insight and be able to make predictions. So there are many, many problems with data, and all of you probably are familiar with some of these at least. There's data from all over the place, so location is a problem. Structure is a problem because there's 90% of medical data is non-structured or unstructured. The format is not all digitized, etc. So there are many, many problems with data that we need to fix before we can really, really benefit from artificial intelligence. And I think that's been, as I said, really, really, the deficiencies were really magnified during this pandemic. But I think there's great hope that we can make this transformation. Just to give you an idea that artificial intelligence is sort of like future. It's already here, but it's just not evenly distributed, as Bill Gibson, the computer scientist, says. This is a short video of what's happening in a few operating rooms. Now, the first half of this video is nothing unusual. Samples collected during a biopsy for a brain tumor. But what is unusual or uncommon is that this sample, instead of being prepared for the pathology lab, which is what typically happens, and you wait a long time, sometimes hours for the results, unfortunately, this sample is processed in a deep learning artificial intelligence tool right in the operating room. And instead of waiting for a long time, this image processing procedure will analyze the picture, give you a percentage prediction of what this could be, and in a matter of 100 seconds. So literally, it's a couple of minutes that you'll have a very, very highly accurate prediction of what it could be. So I think we're in a time where evidence-based medicine, or in the case of healthcare executives, evidence-based practice, is quickly feeling outdated. And I think, again, this pandemic really demonstrated that. A lot of operational aspects of our hospitals was not nimble enough to make a quick change and accommodate a major public health crisis. So we need to go from evidence-based medicine, if we were to practice precision medicine and population health and go to the next century, we really need a major paradigm shift, because the information and knowledge gap, as demonstrated this past few months, is really, really big. So we need what I call intelligence-based medicine, or a very data-driven, data-savvy, analytical period to get us the information and knowledge that we need to practice for the next century. And not just medicine and healthcare, but as well as healthcare administration. And this is particularly important because we're all aspire to someday to have precision medicine and population health. So if you think about that, that's much demand on data and knowledge. And that's because many, many layers of information are going to be available for the first time for us to actually execute a plan for precision medicine, which is something we all want. At the same time, population health is very important too. So we need not just precision medicine, but population health. And that's a very, very big lift for the present. So if you didn't get the graph before, this is a simple graphic. And to just show that evidence-based medicine or practice is what's above the surface of this big iceberg. And we need to start looking underneath the surface for intelligence-based medicine, and hopefully the two combined will be the best practice that we'll ever see. So for those of you who are not familiar with our history of artificial intelligence, I think it's worth time to just briefly outline what's happened in the last few decades. So during the Second World War, Alan Turing, who was made much more famous with the movie The Imitation Game, is really the father or the progenitor of artificial intelligence in my mind. Ironically, he never called it artificial intelligence. He just said it was some sort of machine intelligence. Now, artificial intelligence was coined during a summer project and gathering at Dartmouth College with everyone except Alan Turing. He had already passed around that time in 1956, 57. A group of very august mathematicians, computer scientists got together at Dartmouth and formed basically the first meeting of its kind on artificial intelligence, and that's when the name was coined. So mostly from places like Stanford, MIT, Pittsburgh, Carnegie Mellon, very, very well-known mathematicians and computer scientists. Now, if you look at the history of AI, in terms of milestones, they were all sort of around the computers defeating human champions. It's sort of like the human versus machine sort of ethos. So in the 1990s, as you recall, some of you recall, the IBM supercomputer Deep Blue was able to beat the human contestant with a human champion in chess, Garry Kasparov. And then what really got my attention in terms of getting a more modern education in data science and inspired me to go back to school for it was in 2011 when the human contestants were handily defeated by the IBM supercomputer Watson. By the way, Watson is not of the Sherlock Holmes and Watson fame, but it's more named after the first company president of IBM. And I think this demonstrated that artificial intelligence is opening a new era, and also cognitive computing. So Garry Kasparov's era with the Deep Blue, it was more about what we call expert systems, where the computer learns a lot about human experiences. And we moved on to cognitive computing with IBM Watson. And then lastly, a few years ago, AI is definitely ahead of schedule because it was able to beat the human champion in the game Go. And for those of you who are not familiar with it, this is a much more sophisticated and higher level game compared to chess. And they're 1 to the 170 exponent combinations and configurations possible on the board. So there's no way that a machine just using memory and experiences can really figure out the next move. It really has to be a different kind of machine intelligence, which is deep reinforcement learning. We won't have time to discuss that type of AI, but it's under the umbrella of deep learning, which we'll talk about in a minute. So this really moved, I think, AI forward in a big way. And also, if you look back on the history, several forces and developments came together and converged. One is the sophistication of algorithms from, thanks to work by Jeff Hinton in Canada, Toronto, in the early 2010s. And second development was the tremendous escalation of cloud computing and storage and processing capabilities. And the third important part of this trio of advances was GPUs. Thanks to our gaming industry and all the teenagers playing games, faster processing had to be in place. So all these three forces came together very nicely and favorably for healthcare, because this is what we needed, is some sort of additional machine intelligence added to human cognition. And lastly, we have a tremendous increase in the amount of data, particularly in healthcare. It's said that 70 to 80% of healthcare data was synthesized in the last decade or so, or last few years. A couple of words about the types of artificial intelligence. So the early efforts, humans were definitely superior. Currently, we're about in a tie situation. Not that we should be competing, but some computers are doing narrow tasks like reading MRIs, playing the game Go, classifying cancer, better or as good as human subspecialists. So this is what we call narrow or weak AI. I personally don't like these terms because it has the connotation that AI isn't where it needs to be, but in fact it is. And in the future, as AI exceeds human capacity and performance, I think we're going to be heading into an era of what we call general or strong AI. And I think we'll see in our lifetime in the next 10, 25 years or so, that you'll see AI being capable of duplicating human efforts, including areas of creativity. We'll talk about the recent big event, which is the advent of a natural language processing tool called GPT-3 in a few minutes. But that's yet another big step forward for artificial intelligence. It's also good to think about the different types of artificial intelligence in this way. Unfortunately, all three words start with an A, so it gets a little bit confusing. But there's assisted intelligence from a machine. So think of this as automating a repetitive task. And you'll hear about an aspect of this with a talk later, and also a description of robotic process automation. So there's very little human involvement. It's basically just doing something that it's been programmed. And in healthcare, there are robots that can take a blood sample and do everything, including inputting data from blood work directly. There's a lot of development and discussion, as well as focus now on augmented artificial intelligence. And this is where humans and machines are collaboratively making decisions. And in the business world, it's exemplified by analytics, as well as what's happening on Wall Street. And last year, the lines crossed in which humans are actually not making as many decisions as machines. So that's happening on Wall Street. An example of this in healthcare is Watson for Oncology at MSK for cancer. Even though it had some negative publicity for not accomplishing what it aimed to do, which is to cure cancer, it had some success in terms of getting recognition, as well as showing some promise for the future. I think what's perhaps concerning, but also interesting at the same time, is the autonomous kind of artificial intelligence in healthcare. This is where an intelligent agent or system is autonomously making decisions or helping to make decisions. There's really little or no human involvement necessary. And in real life, we have the autonomous driving vehicle with a few controversies, but overall safer than human-driven vehicles. And for those of you who are wondering if that's ever going to get here in healthcare, it's already here in the form of an autonomous system that can read fundus photographs for diabetic retinopathy. And it's called IDXDR. And think about the tremendous help this would be on a global health situation. So this is a very busy sort of landscape of healthcare and artificial intelligence. And I'm just going to focus on a few of these that will be very relevant for today. By the way, I'm going to be listening in throughout this webinar. And whenever there's a term that may not be familiar to you, I'll be putting an explanation just so you're not going to be lost in the discussion. But we're going to focus not so much on classical machine learning, but that's very relevant for clinicians, but a little bit more on what's deep learning doing, some aspects of natural language processing, just because it's probably the fastest moving area right now in artificial intelligence, with a lot of relevance for healthcare leaders. And then also a few words about robotic process automation. And then we'll talk about AI strategy, which is something that you would be interested in. So this is sort of a nice nest of dolls for artificial intelligence. It's usually under computer science. And deep learning and machine learning sometimes are used interchangeably, but it's important to remember that deep learning is sort of a subtype of machine learning. And it's a more sophisticated way of using machine learning. Machine learning, think of it as sort of souped up statistics with the computer being able to learn looking at the data. rather than us programming the computer to tell it what to do, the machine on its own can really look at the data and make some insights. So that's an exciting area. Now, data science as a term is also thrown about, and you see that there's a rapid convergence of data science and analytics and mining in this area. The common joke is that a data scientist is basically a statistician who works in the Bay Area, but I have a lot more respect for a data scientist. I work with quite a few, and it's because they actually have to do it all. They have to do get the data, clean the data, complete the data, get it into some machine learning model, and then follow up, and then being able to demonstrate the data analytics with visual. So it's a very, very demanding job, but I think it's a fun job in healthcare. And then one of my data scientists that I work with is a mathematician by training, and obviously statistics is an important part of all this. So essentially what we're saying here is that artificial intelligence overlaps greatly with data science and mathematics, and it's basically harnessing this amazing resource with computational power and storage and algorithms to help all of these potential issues in healthcare. Maybe not all, but at least most. So that's just a little cartoon break. All right, so a few words about deep learning. You've heard the term and even machine learning, so I'm not gonna talk about machine learning because that's a talk in and of itself, but again, deep learning is a more sophisticated version of machine learning that mimics the human brain to some degree, but that's a very simplistic interpretation. So when you talk to radiologists and cardiologists and other types of image-focused subspecialists, this is how they're gonna be using deep learning in the form of convolutional neural network. So if you can't remember the longer term, since CNN, you think of the news station and just think of it as an image-focused type of artificial intelligence. It's a very elegant display of the power of computational science, looking at convolution and pooling as two different layers, but this is many hundreds of layers, so it's repeating throughout this whole network of mimicking how the human visual cortex looks at an image by what we call feature extraction and aggregation. So essentially, it's analyzing a picture. Now, algorithms in this format has really been impressive in the last 5 to 10 years in terms of the progress. So on the left is the error rate, and you see with algorithms has fallen now below human in some instances. But I do think there's a lot to be learned about what the fallibilities are with artificial intelligence. Any human will be able to figure out this is alternating pictures of chihuahuas and blueberry muffins. Even my 4-year-old daughter at the time, you notice I was teaching her how to play Go. She was 7 for 7 without any prompting what was a blueberry muffin and what's a chihuahua. But interesting enough, until recently, deep learning was having some trouble differentiating too because of the spatial relationships. So computer is definitely far from perfect. However, this was a landmark article that showed deep learning detecting diabetic retinopathy and was able, so this is an algorithm from Google that was able to be as good or better in terms of accuracy compared to ophthalmologists. And there's one sole ophthalmologist in purple up there in the upper left corner that was able to perform at a higher level than the software. But you can see that he or she is feeling a little bit lonely out there compared to the deep learning algorithm. Another cartoon break, you're not being replaced by a robot, you're being replaced by someone who understands robots. This used to get a few giggles, but I think fewer people are laughing these days because I just saw an advertisement by a radiology department that wanted to recruit a radiologist with a computer vision background. So I think for those of you who are not quite ready to embrace artificial intelligence, I think at least having a basic knowledge is going to be very, very key for the future. Speaking of future, I think I wanted to just say a few words about a couple of areas that are really, really important. One is natural language processing. I've been just amazed at the progress in the last 18 to 24 months in natural language processing. For those of you who may not be familiar with this is a way of humans and computers communicating in terms of processing the information in written or verbal form, or understanding this communication tool called the language, and also generating texts and generating material. So some of the areas that are very important and we already have in our daily lives, machine translation now is instantaneous, even visual translation with a street sign, which is really impressive. There's information retrieval, particularly important for electronic records. There's sentiment analysis in a business sense, but also sentiment analysis in healthcare is going to be very important in terms of how your customers and your patients are feeling about their experience. Information extraction, again, very, very important for healthcare in terms of getting the information that we can't seem to get out of electronic records. And again, this pandemic demonstrated how feeble we were at getting important information to everybody that's actionable. And then question answering in terms of chatbots and virtual assistants is obviously really, really key for the future for communication with patients and families. This is how it works in a very, very simplified form. You basically, on the left, you have someone asking a question. The software then tries to understand not just the words, but the context. And then with machine learning, finding what the appropriate response would be. And then remember, the software has to generate a natural language or human language response, and that's going to be tabulated. And if there's a miss in terms of the understanding the question, and that's going to be put back so that the computer can learn. So the computer is always learning. And some of you may have noticed that the chatbots and virtual assistants are getting better by the month. This is how I would say during my school years, I think natural language processing was my toughest course, or among the toughest few, because all words are very elegant, but very difficult sometimes for machines to understand, particularly what kind of context. And this is just the tasks in natural language processing that are necessary to really get this done. The bottom line is getting something understood and a response back, or getting information from a lot of words. You have to parse the words, you have to put it in the right context, you have to find all sorts of nuances in human language. And natural language processing, by the way, was the major hurdle that IBM supercomputer Watson that I talked about earlier was able to jump over to defeat the human contestants. Although you had some really comical misses, but overall, I think it was amazingly impressive that it could be as good as a human or better in answering questions in general. So, but it's still a very, very complicated process. And this, again, is a what we call the NLP pipeline or workflow. And you take a text document on the left, and you basically slice and dice the language into recognizable parts and put it in the right context. And then you come out with a machine-ready form of this language for it to perhaps have an actionable item. Now, what's been exciting, as I mentioned earlier, is what's happened since July when GPT-3 came out, this generative pre-trained transformer. It's a bunch of nerdy words, but what it's really doing has upped the game of natural language processing by a couple of magnitudes. It has close to, I believe, 200 billion parameters, essentially synapses in equivalent of your brain. So brain has somewhere between 100 to 1,000 trillion synapses, connections between neurons. And GPT-3 is 0.1% of your human brain, but it's getting better. So I think, and it's going to be cheaper. I think it costed multi-billions to build this thing. But within a decade or two, GPT-3 or something in this capacity would be a few $1 million. So it's getting cheaper. And some of you may have heard of BERT, B-E-R-T, which is a bidirectional format of NLP tool. And there's a sort of a joke in Silicon Valley to name NLP tools after Sesame Street characters. So you'll probably you're hearing for the first time that Google's coming out with something that's even better than GPT-3. It's going to be called Big Bird. So Big Bird is going to be something that you'll be hearing about in natural language processing. I think another very important part of using artificial intelligence is using something that can automate something that humans are doing. As my friend and colleague and a speaker later says, you take the robot out of the human. And how many times have you seen your colleagues doing something that was absolutely not necessary if only machines were smarter, right? Or more capable. So if you look at this graph here showing complexity versus automation, robotic process automation is definitely something that we need to take much more advantage of. Not to necessarily just displace human beings, but perhaps reconfigure the human workforce. And I know there's a lot of fear about computers replacing humans, but remember when ATMs came out a few decades ago, the bank branches of banking didn't go away. As a matter of fact, it proliferated, and people inside the banks were just doing things differently. And it's been really pushing the whole industry. So I see the same thing for healthcare. We'll just need to reconfigure our jobs, and perhaps more interesting and more challenging. So if you look at the spectrum of intelligent process automation, or IPA, it goes from robotic process automation, which you'll hear about, to different forms of cognitive automation, digital assistants, and eventually we're going to see a proliferation of autonomous agents, which are essentially sort of like your assistant, essentially, to help do tasks that are even more challenging. So I see the future of AI realistically, but also optimistically. We're sort of been admiring birds in flight and really appreciating what human brains do. But right now with machines, we're at the Wright brothers stage of the progress. And I think within a few decades, we'll be, just like space travel, we'll be traveling farther and faster and higher into space than ever before. So I do see that same exponential increase in progress of artificial intelligence. And speaking of future of artificial intelligence, I think we have a tendency to overestimate the progress of technology and underestimate it in the long term. And I think some of you are familiar with this concept. And I think we're about here. We're still overestimating what AI can do. But if you just follow the green line, I think when I'm expecting in this decade, looking at the progress of some of the elements of AI to really escalate greatly. And then 10 years from now, we'll be looking back on this talk and say, wow, we weren't really expecting much from AI, and look what it can do now. And someday we won't be talking about AI any longer, because it'll just be part of our daily lives, just like it's been part of our daily lives in many formats. And I mean in our daily healthcare lives. When we go to work in the hospitals and health systems, we won't be talking about AI as much as we are now, because everything will just be embedded. And the next wave of AI is going to be more cognition-based AI. So that's going to be beyond the statistical machine and deep learning format of AI. And that's where everyone needs to come back and rejoin the computer and data scientists in terms of formulating possible solutions in healthcare. It's an exciting time for us. As Bill Gates says, we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. But don't let yourself be lulled into inaction, which I think is the most important part of that phrase or paragraph, is that let's be active about adopting this and make changes, make improvements. Don't just sort of sit in the corner and say, well, in the future, this will be part of what we do. We have to create the future, essentially. I think one of the most exciting things is seeing machine intelligence and human intelligence in healthcare, including all the administrative aspects coming together, and perhaps create medical intelligence or healthcare intelligence. And as a demonstration of this, I was a privileged one of the co-chairs for this meeting. It's a datathon in which clinicians as well as data scientists came together over a weekend, and we just basically nerded out and solved research questions with a publicly available database out of MIT. And it was just amazing to see senior clinicians working side by side with data scientists that could be their grandsons and granddaughters, and working together and solve their problems in healthcare. But we do have to be careful in terms of bias. Like a child who learns from a parent, a computer also learns from its creator, us, but it must be in synergy with us. So we do have to be careful about biases and ethical issues, as well as automating biases, and that's going to be part of the discussion today. As the famed Alan Turing that I talked about earlier says, we can only see a short distance ahead, but we can see plenty there that needs to be done. And that's certainly true in healthcare, but I think it's a tremendously exciting era because we can finally, as Neil Gordon says in at one of our meetings in the UK, finally have the escape velocity we need to go to other celestial bodies. So we've been orbiting with AI, but I think it's going to be good to finally get away from the weight of the gravity of healthcare. I think just a few words about AI strategy, because we'll be talking about that quite a bit today. Overall, I think if you want to get started in this area in your organization, I think it's good to form an AI coalition, just people who are interested. They don't have to be experts. They just have to have a dedicated focus on artificial intelligence and assess the AI in your organization. You might be further ahead than you think, just because we don't typically talk across silos. Or you might be far behind and you just have a good reputation for an institution. We've seen that as well. Just because you're a big brand in healthcare, that doesn't mean you have an AI strategy that is robust. I think it's important to provide education in the form of monthly meetings, journal clubs, discussion groups, whatever you like. Provide education for anyone that's interested is very important. I think it's also important to present use cases for clinicians as well as administrators that AI is a resource that you can think about. I think start with small projects. I think one of the lessons we learned from IBM Watson going to MSK was that the expectation was to cure cancer. And I think that's just way too big and way too complex. And I think everyone learned from that. So start with a small project, a clinical project, or an improvement project, and start with a small project and just learn the tools as you do small projects. And then I think it's important to review results, celebrate the successes, make changes for projects that has not met expectation, and iterate. And this is a very similar process, as you know, to other movements we've had in healthcare in terms of quality improvement, in terms of innovation. So these are very similar kinds of moves that an organization needs to undertake. And I think it's essentially more about cultural change than the technology itself. Again, if you want to get started, just like the pandemic for AI, now this is not the end. It's not even the beginning of the end, in the words of Winston Churchill, but it is perhaps the end of the beginning. So I think we're ready to embark. I have a couple of daughters that are also interested in helping people during this pandemic, and hopefully they'll be inspired to go into healthcare as well. For those of you who are interested in AI and want to know how to get started, these are probably the 4 best books in the 4 previous years that I have read, starting with Machine Platform Crowd as an introduction. Prediction Machines actually has quite a bit on healthcare. And Digital Transformation, I think, is a must-read for every healthcare executive, because it talks about AI as well as the digital aspects of our society. And lastly, really probably one of the best comprehensive, readable books on artificial intelligence is AI, A Guide for Thinking Humans by Melanie Mitchell. Speaking of books, I know those of you who've been asking, the book I wrote is out. It's even on Amazon. So far doing well with reviews, but it's called Intelligence-Based Medicine. You remember those words from earlier. And I want to combine AI and human cognition in clinical medicine and healthcare. It has also a section on healthcare administration in terms of where we can go with that. And I'm actually working on a separate, smaller book on AI and for healthcare leaders and executives. So that'll be out within a year. I'm also the editor-in-chief of a journal, academic journal called Intelligence-Based Medicine. We welcome submissions from anyone in healthcare. Particularly, I'm looking for operational aspects of use for AI in healthcare. This is not just for clinical medicine. And I'm working on a video and a book series, as I mentioned earlier. And I think these are all very relevant for healthcare. And also for those of you who would just like a crash course beyond this 25-minute primer, we are starting a series of review courses under the American Board of AI in Medicine. I co-chair that meeting and review course. And we'll start with our first sort of crash course, October 14th and the 15th. It's a 2-day program. I think after these 2 days, you can consider yourself just about an AI expert, at least locally. We'll have a certification assessment process where you can get actually certified. And that will start early next year. So we have a couple of review courses with still spaces available and you can register under abaim.org. And for AI Med, we have usually we have our annual meeting at the Ritz-Carlton in Dana Point here in Southern California, but we hope to see you virtually at the same dates. We just will be doing this virtually and in December. So we really, really look forward to seeing all of you there. I want to thank MI3, my institute that focuses on AI and healthcare, and my donors, Sharon Disney Lund and Michelle Lund, as well as my very patient and good friends at Stanford School of Medicine in the Biomedical Data Science program. And here's my contact information for those of you who are interested in contacting me. My cell phone is there too. Feel free to text me or call me. Want to make sure I'm accessible to anyone interested in AI and healthcare. So with that, I'm going to move on and go on to our next session. I'm going to introduce to you my good friend and colleague, Dr. Arlen Myers, who will take us to the next session that's going to be focusing on an area that he specializes in, telemedicine and digital medicine, and how COVID has changed the world into virtual care. So Arlen, thank you very much.
Thanks very much, Anthony, and thanks for that great review and setting the stage for this conversation about telemedicine and virtual care. I'm Dr. Arlen Myers. I'm the president and CEO of the Society of Physician Entrepreneurs, and as Anthony mentioned, a collaborator with him in several of his outstanding initiatives. So I want to give the opportunity for our guests and our panelists to introduce themselves. So if I could ask each of you to just briefly tell us who you are and your present role, that would be great. Thierry, can you start?
Yes, indeed. Do you hear me?
Yes, thank you.
Okay. Well, thank you very much. And I'm Thierry Messana. I'm a heart surgeon, and I'm the president and CEO of the Ottawa Heart Institute. So for those who are not familiar to our organization, we are probably the largest heart center in Canada. So dealing with a lot of cases, and we have a very large regional impact. So of course, like everybody else, we got hit by the COVID, and we've seen a lot of transformation in healthcare that you probably all have seen. So this is a very exciting meeting to me, and I'm looking forward to the discussion.
Thanks. Nick? Nick, can you introduce yourself? Thanks.
Yeah, great to be here. I'm a practicing internal medicine physician for the past 17 years. Currently serve as Chief Digital Officer and Vice Chair for Innovation at Prisma Health, where I help lead digital health strategy and focus on delivering frictionless care to our patients and driving a seamless workflow for our providers to improve engagement and adoption of virtual health and other emerging technologies. Just a quick background on my organization. Prisma Health is the largest, most comprehensive, locally owned nonprofit hospital in South Carolina. It was formed about 3 years ago after two large healthcare systems, Palmetto Health and Greenville Healthcare System, merged to form Prisma Health. We span over 50% of the state. We have 18 hospitals, 30,000 team members, 2 academic centers, 330 ambulatory practices, and 45% of South Carolina lives within minutes of us. We're also the largest private employer in the state. Since March, since COVID started here, we've conducted over 360,000 virtual visits and had about over 110,000 COVID-19 chatbot engagements. So great to be here.
Great, thanks for joining us. Peter?
Hi, good morning. Thanks, Arlen, and really a great honor to be here and learned a lot already. I'm a Chief Scientific Officer at the University of Ottawa Heart Institute to work with Dr. Masana. And the areas, I'm also a heart failure physician. And so the area that we work in and also have personal experiences on the area of telemedicine, where we actually monitor a large number of patients, particularly with the heart failure with complex conditions. And we gather a lot of data, with some predictive analytics, as well as virtual care. And this is obviously something that is kind of stressed upon us because of the COVID. And so certainly for our care, 90% has been transformed into virtual care as this big cultural change. And Dr. Masana, probably will mention later that, we are the largest provider for focused cardiovascular care in Canada, and located right in the capital. But we also look after patients in the far north. As you know, Canada is kind of a big landmass and with very few people. And so trying to reach that population through virtual care is also another challenge.
Great, thanks. And finally, not finally, Michael?
Good morning. It's great to be with you. I'm Mike Weiss. I'm a general pediatrician, and I'm the Vice President of Population Health at Chalk Children's Hospital here in Orange County. We're a safety net hospital, care for about 750,000 children in our geography, and uniquely in California, have a lot of value-based payment methodology that feeds into some of our care programs. I have the pleasure of overseeing our telehealth program, and like many of you, we were kind of circling the wagons and doing our treading of water, and then COVID hit, and we've now done about 55,000 telehealth visits in primary care, pediatrics, specialty care, speech and language, occupational therapy, behavioral health, mental health, as well as care coordination and autism. So very excited to talk to the group. Thank you.
And David?
Good morning. I'm David Berger. I'm a surgical oncologist by training, and I'm the CEO of University Hospital of Brooklyn, which is the major teaching affiliate of State University of New York Downstate Medical Center. I've been here now, this is the start of my 4th week. Previously, I was at University of Florida, Central Florida, as the Chief Operating Officer and the interim CMO, and I ran the COVID response for 2 hospitals in Central Florida, communities of about 450,000 people, and included the largest retirement community in the country, which is the Villages, which is about 150,000 people all over the age of 55, which is and continues to be a high-risk population. So I coordinated the whole COVID response, from the medical as well as the operational response for those 2 hospitals.
Great, thank you. So if any of the panelists have a question they want to ask, just raise your hand and or a comment, we'll get into it. And just to set the stage, I'm interested in, maybe you could show by a show of hands, how many of you, let's say back in March or February when this thing started, were ready for it? In other words, how many of you actually had some sort of virtual care infrastructure, process, and culture that you had been working on and sort of ramping up, but then obviously you had to deploy when COVID hit. So how many would you say you were reasonably prepared for the epidemic or the pandemic? Great. So 3 were, well, Peter, were you prepared?
Well, I'm with Dr. Masana, so I'll just vote with him.
Okay. So David, you're the lone outsider, correct?
Correct.
Okay, great. Okay, so maybe we can start with David then, since you can share your experience as you indicated, someone who really wasn't ready for prime time when it came to virtual care, telemedicine, mHealth, telehealth, however you want to define it. So can you share with us what happened when COVID hit, and what were your biggest challenges as someone working in an institution previously as a COO, now a CEO in Florida?
So how we were successful and able to ramp up pretty quickly was that I had a very, very creative CIO. And while there hadn't been a lot done on the clinical side, he had begun to develop some of the strategies, including already having a Zoom presence and having some of the hardware in place. But really what was required was to ramp up pretty quickly across the board. And I think really what made us successful in being able to get that done is the fact that our IT people were very, very creative. They did a lot of things, and they were able to piece together a lot of things on their own. And the demand was so high, we were sort of forced within a short period of time to be able to have a telemedicine presence. The other thing that was important for us, especially in the tele-ICU, which was really something that we were very desperate for, because we didn't have a real strong ICU presence, because again, these were community hospitals, not really university hospitals in rural settings. So we didn't have dedicated ICU physicians, and we reached out to our partner, which was the University of Florida, and within 24 hours, we had an EICU up and running. So I think it was the creativity of our CIO and his staff, as well as our partnership with the University of Florida, that made us really enabled us to be able to get this up and running pretty quickly.
So I'll ask the other folks that indicated they were semi-prepared or prepared. What prevented the dissemination and implementation of your virtual care infrastructure, process, and culture prior to COVID, such that when COVID hit, all that seemed to melt away? Michael, maybe you can take that.
Yeah, it's interesting that you use the term melt away, because it really was about the burning platform. I think for us, the major resistance was not around the technology, but more around the operational model and the reimbursement. The relaxing of the federal regulations around COVID was a huge, huge door opener, I'm sure, for everyone. I see heads nodding. And quite frankly, that was really the gating item for us to be able to proceed, number one. And number two, which I'd like us to maybe explore later if we have time, is I am very concerned about what happens on the other side of the bridge when COVID is a past memory and insurance companies start to see their run rates of cost of care rising related to telehealth. What are we going to do collectively as a collaborative?
Nick?
Yeah, we started this journey early on when I took this role about 2 years ago. And as we have all know that we're moving more toward value-based care in healthcare, and we needed to drive out cost. And in Prisma Health, we have over 400,000 people in our value-based care programs. And what we want to do is form a digital continuum. So no matter where a patient enters the system, from either an ambulatory visit or direct admission, or virtual visit, there is a seamless continuum being able to get a patient from one area to the other. And, you know, it was great hearing Anthony talk about robotic process automation, because there is a lot of work that is robotic that we do ingrained in our day. And, you know, I never start with technology first, but start with the need. And the need was essentially is to drive out some of these high cost centers where patients are going, because that was the only avenue they had. So we wanted to offer virtual health to our community. You know, the state of South Carolina is only 5 million people, but we're very spread out in a lot of rural areas. And if you look at the CDC map on our ratings, we're 43rd in the country when it comes to healthcare. We have a lot of diabetes, a lot of hypertension, a lot of stroke, a lot of MI. You know, it's funny, when I traveled to Palo Alto to visit HP, I didn't see one sign for a cardiologist, but you land at my airport, you'll probably see multiple signs for cardiologists. And access to care is a major issue here. So we wanted to open the doors as a digital footprint for patients, even if they can't get to a visit, to have a virtual visit, you know, before they actually get a primary care patient assigned. So for us, it was all about how do we make ourselves more efficient. And obviously, as COVID has happened and federal regulations and state regulations have opened up the floodgates for this, we've seen a great amount of efficiency in how we deliver care. And we're getting into communities that we typically wouldn't be able to reach because they have transportation issues. And now we're able to take care of folks with diabetes and hypertension and other chronic diseases where they are. And so when COVID happened, it was essentially scaling that up, where we were looking at our value-based care or at-risk patients. At first, we wanted to really start to think about all our patients, how we deliver care to every one of our patients, not just our value-based care patients or direct-to-consumer, but how do you provide that for everyone? And of course, it took a lot of education. This is a whole paradigm shift to how providers treat patients, right? From seeing patients in the office and going through front desk and intake to 5 minutes you have with a patient in your 15-minute visit. It was a huge shift, in educating providers on how to talk to a patient on camera and continue that rapport and engagement that you have at bedside was one of our biggest things that we had to challenges that we had to work on, outside of obviously technology and some other things that I'm sure we'll probably go into further.
For other, Nick, for other healthcare executives who are watching this, what is the single biggest or the single most important piece of advice you can offer to scale a virtual care enterprise?
Yeah, number one is to make sure you have both operational and physicians at the table, and obviously IT. One of the biggest things that we had is that we had a lot of computers throughout the system that did not have cameras on them. You know, you try to, like I said, we're, you know, spread out pretty big, and you know, every computer didn't have a monitor, didn't have a camera or a speaker or the appropriate bandwidth. So make sure your IT infrastructure is there to scale, number one. Number two is make sure that you have appropriate physician buy-in through proper education. I think we've all kind of been burnt through the last 10 to 15 years of EHR deployments. It's one of the number one reasons, as you all know, for physician burnout. What we did not want to do is introduce some new technology or new workflow that made things 10 times harder for them and added to that burden. So provider engagement is extremely important, and getting them to give you input into what that workflow should be like. And then obviously it starts at the top, making sure and talking to your chief clinical officer, your CEO, getting buy-in at the highest level that this is important. And if we're going to try to move the needle to be better than 43rd in the country for healthcare, then we have to start thinking about new ways of healthcare delivery and expand beyond the routine office visits so that we can have a bigger impact in the community.
Peter and Terry, maybe you can sort of tag team the answer to this question, but we've heard some advice about scaling virtual health. What are the specific issues you've encountered in scaling heart health?
I can just briefly answer and let Peter as well. So I think for us, we have a 20-year history of telehealth, telemedicine in Ontario, and we were pioneering this. So it was actually quite easy to scale. Plus, we had developed a strategy plan a year ago that was including telehealth and virtual care as one of the central part of our strategy. And again, the geography of Canada demands that actually, because between Ottawa and the Northern Territory, Nunavut, you probably have the same distance as between Miami and New York. So I think what is important is to make sure that the physician engage into the exercise. That's the most important thing. Technology is big. But now we have to look beyond that and say, okay, now we have this video conference. How do we use this to be able to make this an exciting experience? And one thing which I believe is important for executives is to measure the patient satisfaction around virtual care, how happy they are about virtual care. And I think that we're going to find very interesting data. So Peter, maybe you have something else to add.
Yeah, absolutely. Yeah, so I agree with the comments earlier. We definitely have the telemedicine infrastructure. We already have, Epic, the digital medical record system. But the big, incentive was actually the reimbursement, as mentioned earlier. So no question the infrastructure was there, but that was number one. Number two is, of course, there's actually a very, very urgent need. But I think the two ingredients that really made it very, very successful. One is actually excellent communication. Dr. Messana and our leadership group, together with physicians, in fact, have weekly meetings, in fact, twice weekly meetings in terms of this shifting strategy. Physician groups actually get together with the IT folks to actually, sort of troubleshoot and share the best practices, very, very short order. The third aspect is actually engaging patients. In fact, patients tell us they love this virtual care. They no longer have to drive long distances. They no longer have to find parking, and they no longer have to wait. And when time comes, everybody connects. But now the challenge that we face is how to actually match the technology intensity, how to mix the inpatient sort of in-face meeting with the virtual meeting. So we're developing, and based on the data available, sort of prioritization strategies, risk-based, allocation. So these are really things that can take advantage of the AI type of tools to improve this further. So how to get to the other side.
David?
Yeah, I just wanted to make a comment about what was some of the factors driving virtual care. So certainly, as Michael pointed out, there was an important issue with reimbursement. And I think everyone would agree that that really helped to drive the implementation of virtual care. But also there was a change in how physicians looked at virtual care. So physicians were really, especially in the community, were really struggling because people did not want to come into the office. Office workers were also worried about patients coming in who were potentially COVID positive. So there was a real move on the physician part to try to implement this as quickly as possible so they can maintain their business. So not only was there a reimbursement issue and a patient satisfaction issue, which Peter pointed out, but physicians were really driving this as well because they wanted to continue being able to see their patients.
So if I may.
Okay, I want to.
Oren,
go ahead.
Just really briefly, I think to any executive who is potentially facing this problem, I would say, just as was mentioned, it's very important to engage physician and patient as well. We have, for instance, a lot of patient alumni structure here, which gives feedback of our virtual care. So we know from our patients how happy they are. And so when physicians hear that, they are prone to change their behavior.
Okay, so we have about 15 minutes left, and I want to just go over a couple of issues that we've sort of alluded to. One is what I would discuss or call the values gap. We're all trying to use these technologies to improve care, the quality of care, reduce the cost, improve the patient and the doctor or healthcare professional experience, and eliminate or minimize administrivia and costly administrative overhead. So it's what I call the quintuple aim, not just the quadruple aim. So My question to that is, and my observation is that because there are so many stakeholders in sick care, doctors, payers, patients, third parties, et cetera, they each have a different objective, a primary objective using virtual care. My observation is that patients want convenience care. Doctors want quality care. Employers want lower cost. CEOs want reducing administrivia and kind of predicting, we had this conversation before, for example, how do you predict bed utilization and demand management and all the processes in a hospital? So everybody's got like a different thing they want out of this. So my question is, do you agree with that? And David, maybe you can allude to this because we had this conversation briefly. When it comes to demand management, predicting administrative flow, whether it's bed capacity, whether it's OR capacity, whether it's how many nurses do you need on a given shift, et cetera, what are your thoughts about that?
So I think if I'm hearing you right, Arlen, and please correct me, you're asking the question about the issue of AI impacting administrative and flow in the hospital, or telehealth?
Well, that's part of it, but I guess the main part of the question is, how do you align the values? Because you as an administrator may, let's take, for example, the point you brought up, like how do you predict bed utilization and the demand and use for beds? And the doctors may have a certain idea about that, whereas you and your administrative or your C-suite staff may, and all the people in between, so that they tend to value different things. So as a CEO, how do you align the values to drive this through the organization?
So I think
because if I'm a doc with a patient in the hospital and you say, well, look, go ahead.
So I think the values have to align.
David?
I think the values have to align around the care of the patient, right? So how do you deliver quality care in a cost-effective, efficient manner? And if you focus on those three things, I think you're able to align both the administrative side as well as the physician and the other provider side. So really, to me, whenever I bring up an issue, and I think that's one advantage physicians have in terms of being administrators in hospitals and healthcare systems, is that we understand the delivery of clinical care. So by focusing on how that's going to impact the patient, I think that's really the best way to get alignment.
Arlen, it's Mike. It's interesting. What you've described is what I kind of allude to as finding the sweet spot. And interestingly, just our case study at Chalk Children's, we were in the midst of what we called an enterprise master plan, which was we were getting ready to look at our entire facility, hundreds of thousands of square feet. And then COVID hit. And when you are starting to look at building a new facility, you're certainly looking at exactly what you described: how many beds, what kind of ambulatory space, et cetera. And when COVID hit, we saw that pendulum go to one side where 70, 80, 90% of visits were telehealth. And over time, we've seen it kind of centralize. And we're really trying to determine what is that sweet spot. I think that's a challenge for all of us. We know it's not 5% telehealth. We know it's not 95%. And it's going to be variable. We're in a unique situation being 100% pediatric. There are many things we cannot do. Cardiothoracic surgeons can't do a bypass surgery via telehealth, right? So I think what we're in the middle of right now is determining what that sweet spot is. And the last thing that I would say is that we have not yet identified what are the quality metrics around telehealth that we need to be monitoring. Everybody's looking at volumes, patient satisfaction, provider satisfaction, those types of things. But I would submit that if I have children with diabetes and I can randomize them into 4 in-person visits a year or 2 in-person and 2 telehealth, and I can follow that hemoglobin A1C over the course of the year, which of those cohorts has a better outcome? To me, those are the types of outcomes that we need to look at.
Okay, there was a brief question from someone in the audience about the difference in the Canadian system versus the US system, and actually some surprise that reimbursement was that big of a deal as a barrier. Could you just briefly address that, Peter or Terry?
Go ahead, Peter.
Yeah. So what happened that previously the reimbursement for physicians are all for face-to-face, sort of on-the-spot patient care, and there is a virtual care, but it's actually very, very specific. It's actually using the Ontario Telemedicine network, and you have to use their hardware specifically. If you use other devices or things like that, are not reimbursed. That was pre-COVID. But of course, at the moment COVID arrived, all that has changed because of the changing environment and demand from the patients. And so they all actually opened up the reimbursement. And there's no question that the moment that reimbursement code became available, it really allowed everyone to then take advantage, not only the Ontario Telemedicine network, but other type of hardware that was available. And if I can kind of follow up on the question that was asked earlier about, sort of things in which can help us, to get to the other side. The other thing besides the technology, besides I absolutely agree with the patient centeredness. That is really, where everybody can, sort of converge their efforts and energy, focus on. But the other aspect is actually data. And, so I think having the data available so that we can, for example, Dr. Messana has now really integrated a huge amount of data at our institution to predict, for example, ICU stay, sort of duration of stay, risk profile of patients. And so we can calibrate the risk to the technology. And then the other aspect is actually digital innovation. For example, we're now testing a platform that actually allows virtual care, not just kind of face-to-face, but in fact, it brings in the patient care partners. It brings in community service, both synchronously and asynchronously. And this, is actually linked to the electronic medical record. So this has enabled, sort of a huge amount of flexibility in terms of care, so that you're not dependent either at home or hospital, but in fact, you can actually provide a care in between as well.
So just to follow what Peter said, for those who have heart surgeons in your hospital, one of our anesthetists is also an AI scientist, and she has access to all data in Ontario. So this is tens of thousands of open heart surgery for the last 10 years. She has developed a predicting tool for ICU stay for cardiac surgery. And this tool actually is available on our website free of charge. It's called Cardio Ottawa. So you can go there online. You put like 10 criteria of your patient going to open heart surgery, and it gives you the length of stay with a 95% predictability. So you can predict in the ICU. So you can predict your ICU stay. This kind of thing that AI can do. So this was great. It's accessible on our website free of charge.
Great, thank you.
That's Canada.
We only have about 6 minutes. We only have about 6 minutes left, and I want to just get to the answer or get to your thoughts on, where are we now? Where do we want to go, and how do we want to get there? And this is about getting to the other side of the bridge. And if we are going to, as Anthony is implying, get us to intelligence-based medicine, then we're going to see, and already are seeing, further dissemination of collision technologies, whether it's remote patient monitoring, whether it's remote sensing, whether it's AI, whether it's nano, you name it. So this thing is going to continue to evolve and evolve and evolve to the point where we're going to have to kind of rethink a whole bunch of stuff, not the least of which is medical education, graduate medical education, the kinds of people that we need working in hospitals, the infrastructure that we need, the leadership we need, the culture that we need, et cetera, et cetera, et cetera, and the rules, not the least of which are they going to keep paying for all this stuff? And actually they is we, because we're the ones that are paying for all this, whether you're in Canada or whether you're in the United States. Ultimately, it's coming out of our pocketbook. So final thoughts. Michael, How are we going to get to the promised land?
So I say I'll give you two answers quickly because I know we're short on time. First is data. We need outcomes. I think what we're going to need to do is demonstrate to ourselves and to payers that we can provide high quality care in an objectively measured way at a lower cost. That bottom line is what's going to drive the sustainability of this. And secondly, as it relates to AI, and I can look at it from my pediatric centric view, we're going to need technology that's going to be able to enhance our ability to provide a better physical exam virtually. We have peripherals for heart rate and pulse ox and things like that, but we've got to be able to do a better job, whether that's avatar, artificial intelligence intaking information from peripherals or whatever it may be, but we're going to have to enhance the technology to get a better physical exam.
Yeah, this is Nick. I'll add to that, to Michael's comments. If that's the biggest silver lining to this pandemic, this hopefully will end up with a modern day healthcare system. I've said that over and over again. And AI is going to play a very large part in virtual healthcare delivery. And to add to what Michael says, yeah, absolutely, it comes down to outcomes. But you have to think about virtual or digital health beyond just video. It's RPM, it's automation, it's chatbots, it's wearables, it's ingestibles, it's a whole bunch of things. At the end of the day, it comes down to data. And I think automation has a large part to play in digital health. You could use AI for a digital system to help triage and close care gaps automatically. We're doing that now. Also, we're rapidly expanding RPM, so I can have wearables to a whole bunch of patients. And then even from a CRM standpoint, when a call agency gets a call or has to engage with a patient, okay, Mr. Smith has these 3 wearables. He's also enrolled in this program or X program. So you're able to now start to do a lot better engagement with these patients. And then AI, depending on how we siphon the data and how seamless it comes through, it could be the air traffic controller triaging that data, engaging patients through voice assistants or other chatbot technology. If you look at Amwell, they've partnered with Google, and they have bigger aspirations around artificial intelligence and harnessing the power of big data. And Google's actually taken a strategic partnership with Amwell with a $100 million investment. And so it's I'm sorry?
No, I just want to, I'm sorry I need to interrupt you, but we don't have that much time. I want to get David's response. So David, how are you preparing your people, medical students, residents, doctors, health professionals, staff, to win the 4th industrial revolution and get us to the promised land?
So I have a tremendous strategy that I put together in the last 3 weeks. I'm joking. But I want to answer the previous question in terms of
we only have 1 minute,
and I'll answer it in 1 minute. I think we need to collaborate across institutions. There is so much in the startup space. It's impossible for any one hospital or any one health system to be able to evaluate and vet all that's going on in the digital space. I really think there needs to be collaboration, and SOAP is an excellent organization to start some of that, but we need to be able to collaborate across organizations in order to vet and determine what are the best digital systems to move forward.
Great. Well, unfortunately, thanks very much to everybody. Terry, Nick, Peter, Michael, David. We could talk about this a lot, and hopefully we will talk about it a lot more on this platform. Thanks very much for your insights, and I'm sure the audience appreciates your wisdom. Thanks very much.
Thank you.
I'll turn it back over to Alexis.
Thanks.
Thanks, everybody, for a great first session. Just to go on from David's last point regarding collaboration, that's exactly the purpose of the AI Med Connect platform as well. We'll run some information during this 30-minute comfort break. Please do continue to use the chat. We can see lots of great questions coming through, so thank you so much for that. And we will be back in 30 minutes for a keynote session from Sean Lane, CEO of Olive. We will see you on the other side. Thank you.
Well, welcome back from your comfort break, and after a pretty lively couple of morning sessions already. So just to keep the momentum, we brought in a special guest of ours, a longtime favorite of AI Med, Sean Lane, who is the founder and head of Olive, and it's a company that specializes in something I talked about earlier during the primer, which is robotic process automation. I even borrowed one of his favorite lines, which is in healthcare, there's so many people doing robotic things that we need to take the robot out of the human. So Sean's gonna enlighten us on his amazing journey in getting robotic process automation to be adopted in healthcare and some of the early successes. And then we'll have a brief chat afterwards. So Sean?
Great. Thank you so much, Anthony. It's great to be here. It's good to see you again. And I look forward to our conversation. I'm going to share my screen and walk you through a presentation. The presentation today I call One Giant Leap, because I do truly believe that artificial intelligence is a giant leap for humankind. I think we will achieve so much more as a humankind as a result of this. So it's really exciting. It will be the biggest change in our lifetime. It'll have more impact than the internet, more impact than, indoor air conditioning or electricity. It'll be absolutely extraordinary. So I'm excited about the future. So just to get started, talk a little bit about my past. I'm actually an intelligence officer by background and training. Spent most of my career at the National Security Agency at NSA. This is my war picture, but I really look like this. Even though I was in the spy agency, I was really a technologist. I built programs, I built databases, I led teams of software engineers, got a real crash course in technology. The biggest big data problem you could ever imagine, we dealt with, and built a lot of software, spent a lot of time in Iraq and Afghanistan. I decided in 2007, it was time to get out and start a family. And I noticed something when I was working in the Department of Defense, and it was that the military was communicating using walkie-talkies. And these walkie-talkies made it really difficult for me to pass information to people on the front lines. And what occurred to me was that, lo and behold, the tactical warfighter didn't have the internet. And without the internet, I couldn't pass them intelligence information. They couldn't pass intelligence information back to me. I couldn't send them maps and pictures and link diagrams, and they couldn't send me back hard drives and data from a phone and things like that. So it's a real problem. So I wanted to create basically the internet for the battlefield, and it looked like this. So this was my first company. It was called BTS. We built these cellular networks in a box to create the internet for the tactical edge of the battlefield, for the warfighters to send them data. And now soldiers and warfighters can communicate with smartphones. We can pass them data. They can pass data back to us. It's secure. And it just makes, the internet makes, the whole process of warfighting different and better. So fast forward, sold that company in 2011. And that's when I started to look at healthcare. My hometown, it's a town called Gallipolis, Ohio, in the southeastern Ohio, very rural. For those of you who know Bob Evans, the restaurant, Bob was from my hometown. That's pretty much our only claim to fame. I was, really taken aback by the struggles we were having in my hometown with prescription drug abuse. I was going to funerals of my classmates. My family was affected by it. And then leaders from my hometown came to Baltimore, where I was living, and asked if I could help with this problem. And I just sold a company, and I was looking for something to really sink my teeth into, and said, let me look at this problem in healthcare and see if there's anything that I can do from a technology perspective to help it. And what I realized after a quick look at healthcare was, wait a second, healthcare doesn't have the internet. So that same problem that I had seen before, basically no connectivity, no ability to share information, no way to even know who a patient is in different systems, allowed for people to divert prescription drugs. and it created a ton of costs. And healthcare did share information, but they did it in a different way with a router. But the router looked like this, a human router. So healthcare, because there's no interoperability between systems, and because systems don't talk to each other, they're human routers that sit in cubicles all day long, type in the same exact thing over and over again, click on the same websites and software every day. And basically you have all of these routers in healthcare. Every health system you go to is hundreds of routers sending information. And this is the backbone of healthcare's internet. Healthcare is not the first person to put the robot into the human, to say kind of the reverse of what Anthony led with. It was this guy. He kind of started it. This is Henry Ford, and he built this assembly line. And the assembly line was really humans doing robotic things, screwing the same screw, affixing the same piece of hardware, welding the same spot, adding the same piece over and over and over again, repetitively, constantly. This was when humans became robots. But if you look at the assembly line today, it looks nothing like this. It's fully automated. And now here's the thing. This assembly line looks a lot like a rev cycle organization today, or anywhere inside the health system. So healthcare, why healthcare? Why focus on healthcare? Well, there are 16 million humans that work in healthcare. It is the #1 employer in the United States over every other industry, over retail, over manufacturing, over oil and gas, you name it. Healthcare is the #1 employer. And 25% of those 16 million employees are doing administrative tasks. They're doing those robotic tasks, and they're effectively the routers. So that's 4 million routers. And that's an incredible amount of cost. Now, those routers can be found spending 8 billion hours a year doing the same thing over and over and over again. 8 billion hours. So imagine if we were to free up 8 billion hours of human capacity, what we could do. It would be extraordinary. And you'll find these human routers in places like RevCycle, supply chain, finance, HR, IT, pharmacy operations, you name it, across the enterprise. You're going to find them in payers. You're going to find them in providers. It's all across the healthcare industry. And if we get this right, if we create an AI workforce that can come in and relieve some of this cost and move and allow human workers to become superhuman workers and do things that they have the capacity to do, we could move $1 trillion of cost. Imagine that. Imagine with a giant bulldozer moving $1 trillion. It's incredible what we could do. And the way we're going to do it is through an AI workforce. So an AI workforce is a new kind of workforce. Together with the human workforce, it will create the total workforce of healthcare. So as you look at healthcare in the future, you'll say, okay, what's the workforce? How much of it's AI workforce and how much of it is human? And now that adds all this capacity. Well, as Anthony mentioned, robotic process automation is at the nucleus of this AI workforce. It's really important to our strategy, and it's part of the technology. We also use computer vision, machine learning, deep learning. All these things you've heard about when you hear about AI manifest themselves into an AI worker. So ultimately, they're not just algorithms. They're not just a brain in a jar. They are actual workers that get things done, that show up, that do the job. Well, we call ours Olive, and that's the AI workforce and worker that we've created. So in Olive, we have this promise that we go to the market with. And we start with this sentence, and it has lots of phrases, but each phrase is important. First is, Olive figures out where she can have an impact. There's lots of things to automate, but you don't want to automate everything. You want to automate the things that can have the biggest impact first. And we use a lot of software and a lot of technology to figure out where to have the impact the fastest. And then we get this thing started fast. Your AI worker needs to show up for work very quickly. It shouldn't be like a 6-month process. They need to get trained just as fast as your humans would get trained. Then they need to show up for work every single day. No days off, no sick days. Unlike a human workforce, an AI workforce works 365, 24/7. There's no downtime. And it takes a really incredible operation to make that happen. The AI worker should also do, in our case, her job extremely well. That doesn't mean just photocopying what the human does. That means finding best practices on these jobs and training to that. Whatever the best way to do claim statusing should be the way that these AI workers do it. They are a network. They are sharing information. So they should all be at the same level of intelligence. And then the last piece is they get smarter over time. AI workers learn together. They are, again, a network. When one olive learns, all olives learn. Just like a self-driving car system, when one gets into an accident, they all learn from that accident, unlike a human getting into an accident. At Olive, we break an AI workforce into two phases. Alpha, which is from the very idea of what they're going to automate all the way through to inception. And then Omega, which is from inception through its entire life. So an alpha is where we prospect, we find things, we figure out the financial impact, we map out the workflows, and we build the robots. Omega is where we watch the robots every single day, making sure they show up for work, do their job, do it well. We analyze the data that's traversing our robot workforce. We communicate from Olive to the human worker so they know and have the latest and greatest on what Olive is doing. And we constantly improve Olive inside of the Omega phase. In the middle of the two phases is what we call Deep Purple. Deep Purple is Olive's brain. And it's where we store all of her memories, everything that she's learned. Today, there are about 400 terabytes in Olive's brain, known as Deep Purple. In Deep Purple, we have all these shared memories, this collective wisdom, how to do the job the right way. We have entity resolution and global awareness, which allows us to tie everything to a person, place, or thing across the entire network. And it's where new discoveries are found, learned, collected, and then manifested into the work that Olive is doing. Another thing that we do that's very unique is this idea of outposts. We actually put outposts, like actual physical workspaces, inside our customers. So we put these outposts inside health systems. We call them alpha sites. And this is what they look like. This is an actual alpha site. We are up to, I think, 9 alpha sites now across the country. These alpha sites are like command centers for artificial intelligence and innovation. We work there with engineers. We track the entire AI workforce. Like if you wanted to walk into the nerve center of an AI workforce, it's at the alpha site. And at every single alpha site, there's a 20-foot LED wall. And on that wall, you can see exactly where your AI workforce is deployed. And in the center of that, how much value they've generated. So here's another thing I want to talk to you about just before we end and go to questions. And it's our strategy for the future. So unlike a lot of companies who shield what they're doing and keep it very, very secret, I am declassifying our vision. I'm showing the world what we plan to do because we're going to need a lot of allies to pull it off. And here's what it looks like. We call it our strategic maneuvers. And there's 5 things that we're going to do over the long arc of time. And over the long arc of time, we will have created this internet of healthcare, and we're doing it with an AI workforce. And let me explain how that works. Most of what I've described to you today is Olive Works. It's the unattended bot. It's the workhorse of the AI workforce. It's Olive working in the cloud at night, working through huge volumes of tasks, claim status, prior authorization, eligibility, you name it. It is the keep the lights on type of work at a health system. The second strategic maneuver is Olive Helps. Think about this as an Olive for every human worker. It's Olive living on your desktop, turning human workers into superhuman workers, giving them the capability to, and all the intelligence from a large, vast community of partners so that they can never code something the wrong way, never miss insurance information, never miss a diagnosis that is important. Olive Helps is like augmented reality for every human worker. And that rolls out very, very soon. The next strategic maneuver is Olive Shares. This is Olive to Olive communications, sending data from one Olive to another, like medical records, labs, test results, care plans, from an Olive in Texas to an Olive in San Diego. The next strategic maneuver is called Olive Knows. This is where we've used that incredible data asset. Today it's 400 terabytes. In a couple of years, it'll be 400 petabytes. And pointing that towards allowing clinicians to know what Olive knows, to connect the folks who have worked on an extraordinarily rare disease together, to illuminate clinical trials that exist that could be right for a particular patient. Olive knows is basically our way of taking that wisdom that we've gained and putting it in the hands of the clinicians. And at the center of this whole strategy is something we call Olive Assures. Olive Assures has a vision that in 5 years from now, we will have assured a health system completely from end to end, meaning they get paid immediately for every single claim. They get paid immediately for every single patient responsible payment. We do that one code at a time by Olive prepaying codes and claims based on a machine learning algorithm to determine the likelihood of it getting paid, and then helping the humans do things that will increase the likelihood of it getting paid. So that's it. That's our total vision across the board. We think if we do this, we'll create this incredible internet of healthcare that will just create, hopefully $1 trillion of excess resources and a huge amount of excess human capacity. So thanks for listening. I think I hit right around 15 minutes, and I'd love to answer some questions.
Thank you, Sean, for that amazing vision and executing, which is the hard part. We all know that. So a few questions. First of all, thank you for coming and sharing your vision. It's so inspiring to hear someone outside of healthcare, and probably took someone outside of healthcare to see healthcare and say, what's happening here, right? So your insight into healthcare is totally right. I'm almost embarrassed sometimes talking about some of the things that we do in healthcare when I talk to my AI colleagues and friends. So you see hope, obviously, for the future, but what is it going to take? So you're at almost a dozen places now. What distinguishes these centers that that had the insight to say, well, this is such a no-brainer that we get this implemented? Yeah. And what distinguishes them, you think, from a healthcare leader perspective?
Yeah, it's a great question. So I think that the technology companies have actually not provided a lot of options to healthcare administrators in the past. And I take, as a tech entrepreneur, I take responsibility for that. And I think that we have not given them a lot of great options. So, and it tends to be everyone's first step to criticize the administrations inside these health systems. Like, oh, the executive team, they don't have vision, they're risk averse. I've found that to be completely opposite. I think they are very innovative, and I think they're very willing to take the right steps, but their options are limited. So we wanted to give them great options. And we are in 60 plus health systems to some degree. We're in 600 plus hospitals to some degree, but about a dozen have made this really big commitment where they're saying, look, we believe that some big portion of our workforce in the future is going to be AI, to the point where we're willing to commit to building that AI workforce from the inside out. And that I haven't even seen enterprises do that. And I can tell you this, I think that the executives inside healthcare are more innovative than executives inside other enterprises because it's a life or death scenario. Mm-hmm. So they're willing to take risks when those risks can produce more lives, but they're also very careful in what directly affects kind of patient care and clinical support and decisions, but they're willing to walk that path. So I'm actually excited about that. And I just think more people need to look at what the leaders have done and kind of follow suit.
Yeah. So I bet quite a few hospitals wish they had some automation in place when this pandemic really hit us in full force. So what have you seen? And your perspective is almost unique in terms of being the leader in this area in so many health systems. What have they gotten back to you in terms of insights. Well, we're glad that we had that in place, because otherwise this was not doable. Because we had a robust discussion this morning about, being forced into a place where you have to innovate very quickly. But the people that have already innovated to some degree with this probably felt a sigh of relief, right? What was your impression?
Yeah, no, I think that's exactly right. So when this started happening, I mean, all of our customers were on the front lines of the pandemic, right? Obviously, when we are, we serve those who serve. We serve those who care for others. And so it's our role as kind of the people behind the sidekick to the hero, if you will, to kind of, to help to really take that job seriously. And, they were on the front lines. And fortunately for the ones who had adopted Olive, they didn't see a disruption in any of those things. So there were realizations that occurred, and this pandemic really spurred those realizations. One, it revealed that a lot of critical infrastructure tasks that kept the lights on inside the organization were done by humans. It revealed that billing was done by humans, that claims were done by humans, that insurance was done by humans. And really, that's risky. It's risky when things like global health or global pandemics occur. So for the ones who had Olive in place, there was no disruption. For those who didn't have Olive in place, there was disruption, but we came in to try to help as best we could. And then at the end of all this, that's as things have started to stabilize for some health systems, we are part of the recovery plan and the continuity of operations plan too. Yeah. So I think a lot of realizations have occurred. I always, when I was in the intelligence community, 9/11 caused innovation. It was the moment. Yeah, it was the moment that broke down silos and barriers and walls, and everyone was ready to go. And I don't. This wasn't as acute as 9/11, but it was certainly as impactful.
Yeah, it's interesting because you and I, you may or may not remember, but we had a discussion about 4 or 5 years ago, and I think
9/11.
Yeah, I told you that I wrote a paper while I was in school comparing military intelligence and health and medical intelligence, and compared and contrasted them. And I said, maybe I was more prescient than I wanted to be at the time. I said, we're just not going to have a 9/11 moment to galvanize the intelligence community like 9/11 did for the military intelligence. And sure enough, we ended up having, I think, a near, if not comparable, moment to 9/11 in terms of global impact. So give us some tangible examples of how the health systems have navigated. And I think RPA is nice because it's pandemic proof, at least for now, that the humans kind of were furloughed or had to have time off. But the nice thing about RPA is just keeps going, and it can be held back without any serious consequences to health systems. Yeah. So give us some tangible examples what you've seen during this interesting time in our lives.
Absolutely. So, a lot of health systems did not have the infrastructure in place for thousands of people to instantly be remote, which neither did many, Fortune 500 companies, right? So this was a big move to basically say, I'm shutting the doors and you're all going to go work from home. And by the way, you're going to work with the nation's most sensitive data from your living room. And we're not ready for that. And it's just that was just the real tangible thing is, let's have the software robots trained to do this so they can continue to operate from one day to the next in the cloud very securely. But it also allowed for those health systems that had adopted something like this, it gave them a little bit of like grace in the process, right? So it gave them the ability to not freak out basically when they had to go through this transition. And it's because there was a backstop. There was something there to continue to keep the lights on. And it helped that transition occur. But I think the what's on the other side of this is really exciting, because what's on the other side of this is we always talk about the ROI of technology. Mm-hmm. We have to move from talking about ROI of technology to talking about ROI of human workers. And it's about increasing the ROI of a human worker. That's what's really exciting. And the fact is, we are now moving human workers up the ladder so that their work is more impactful. It's creating more investment, return on that investment. And that's what's really, really exciting. And that comes at the tail end of this, which I think is neat.
I have a relatively difficult question. So if you're up for it,
I'm
Sean.
up for it.
So this is from one of our attendees. How can you share how Olive imagines accounting for the payer regulations, machine learning algorithms, along with clinical documentation discrepancies across disjointed regulatory landscape for a single country that is attempting to shift reimbursement coding from fee schedule to value-based care? So how do you, is it natural language processing? Is it regression models? And it's so tricky and difficult. How do you see that happening?
Yeah. And I would say stay tuned in the very near future, and you will hear some interesting announcements from around this area.
Yeah,
because,
I think it's. Yeah, go ahead.
Yeah, we need to invest, and that means we, as in tech companies like Olive, in a rule set that is dynamic and updated with every single one of the payer contracts and rules that exist, and the formularies, for that matter, of how they decide on what gets paid and what doesn't. And we need to be able to use machine learning on the data that we already have to help determine and predict that. That's step one. Now, how it gets to value-based care, I think, is through a path that starts with assuring claims, getting them paid immediately. And then over time, what we start to do is negotiate, because if every single claim is getting paid immediately, and then the arbitrage between the kind of the number of the dollar amount of the claim and then when it gets actually remitted, is what you have to work with to negotiate with the payer to move into more of a value-based world and start actually looking at health results to determine that. But there is a heterogeneous landscape of data today with every single payer and every contract they have with every provider. And I wish there was a better answer than just straight up like natural language processing on the contracts. It's elbow grease. It's technical elbow grease, creating a dynamic system that is constantly synchronized and updated to inform your rule, to inform your decision making, to inform your machine learning algorithms.
Yeah, I really do think we're still vastly under leveraging NLP in healthcare when the world has just taken off in that area, especially in the last even 6 to 12 months. The world's changed in that domain. So I think there is, yet another important resource for us in the future. So last closing comment and question, John, should we, what should we all pay attention to and try to do to adopt this kind of resource, not just RPA, but just AI in general? What do you think healthcare leaders should really do this time? I know there's wider acceptance, but execution-wise, we're still fall short.
I think that for a health system, there's this gravitational pull to build robots. I would say don't build robots. I would say look at platforms such as Olive Helps, which is the one that we're coming out with, that allow you to build capabilities that in your health system to turn your human workers into superhuman workers. Focus not on generating the ROI of the robot, but focus on increasing the ROI of the human. And you can do that in like little tweaks. That it doesn't have to be, you don't have to cure, rare diseases. You have to help the person working in revenue cycle find the right insurance. That's like step one. Let's do all that across the board, and let's commoditize that. So that would be where I'd say to start. And, in the future, like there will be a lot of opportunities for health systems to get involved in the sausage making of creating a lot of these tools.
Yeah, no, I absolutely agree. I think we have to have just like we have a balance between machine intelligence and human intelligence, we need to have a balance between solving the enigmas of clinical medicine at the same time, neutralizing the many inefficiencies in healthcare in general. So thank you for that balanced perspective. And again, always welcome at AI Med. So I'm going to hand over to David Levian, a good friend and colleague, who will guide us through the next session on real live use cases of AI in healthcare.
Well,
David.
thank you very much, Anthony, and great talks, everyone. The next session is a 30-minute session, and it's on use cases and harnessing the power of artificial intelligence. We'll have two 10-minute presentations. Each speaker will introduce themselves, and then we'll have 10 minutes for questions. So at this point, I would invite Dr. Robert Sumter to briefly introduce himself and take it away with the presentation.
All right. Hey, thank you. I'm Rob Sumter. Just to give a little bit about my background, I serve as the interim deputy CEO of a health system, and also I serve as a chief information officer. And what I'm doing here is my job is to really define technology on my chief information officer side that brings solutions, not products, but actually bring solutions to the organization so that it helps to advance the organization forward. And one of those things that I've been focused on is artificial intelligence and how we could better utilize artificial intelligence within the healthcare environment. I certainly want to thank Sean for what he's presented and have a conversation with him after this more, because it's more of the vision that I have for this organization and healthcare in general, to utilize artificial intelligence and get everybody to know that it becomes an augmentation first. It's not a replacement of the human being. So to talk about some of the real live things that we've been doing to utilize artificial intelligence really is to go and focus on the revenue cycle piece of it. When you take a look at the revenue cycle, what we have here at the health system that I work at, we ran into some issues that we needed to talk about. And this is my slide that talks about what healthcare is going to look like in the future as we get into artificial intelligence. And many of these things are already being tested. When you look at, in radiology, artificial intelligence is being tested there, because when you do a CT scan and those type things, it's basically the same with the human body. It's reading the information and being able to make a diagnosis or a determination of what they have in there. So a lot of that is still being worked. Where it has gone is really into the revenue cycle where we use it. So when you take a look at the revenue cycle, we have issues. We still have issues that we're working through. We've implemented the artificial intelligence and we continue to move and implement it. Our problem we started out with, we have a very high claims denial rate, which is 30%. If you're in healthcare, 30% is extremely too high. You should have 5% or less, which is, the benchmark. We have a high number of days in our accounts receivable. Everybody know the match there is you want to be around 45, 40 days or less with your accounts receivable, because that's money that comes in. And then we have a very high number of days in our discharge not final bill, which is 14, and you want to be a lot less than 14. And this significantly impacts the revenue collection and our cash flow of a health system. And so we had to take a look at things that we can do to improve that, because we have the staff here. Your question goes, do you retrain your staff to be able to be more efficient? Do you hire more staff, bring in additional staff? Do you double that staff, triple that staff to be able to do what you need to do? Our proposed solution, because artificial intelligence has gotten to a point where we actually could use it in revenue cycle, we wanted to implement artificial intelligence and machine learning language for our authorization, professional fee billing, and accounts receivable, where it can actually do the analysis. We expected our return on investment to reduce our denial rates, reduce the reduction in our accounts receivable days, and reduce our DNF fees, and also improve our cash flow. In implementing the AI, in that, what we found as we started to implement the AI, there are a lot of things that we on the human side were not doing that impacted the artificial intelligence to be able to get it right. Because when you start putting in the bots and RPAs, you put those things in place, it does a mimic in a lot of places until it learns, what it needs to do. So it mimics that human being. In our particular case, it realized that in our system, in our revenue cycle, we had no standardization. And so that means that when a provider did a documentation, it could be anywhere in the medical record. And so that meant that our clerks, our coders, had to go through that entire medical record to find out where things was located. That meant a lot of time, because we had the question, why does it take our coders so long to code a record? They're coding less than the average. We found out the reason they were coding, it took them so long to code, is because we don't have standardization in our records. We're putting the documentation in there, but it's not in a place where you can easily find. And so we found that out with the artificial intelligence, which we put it in, and it was able to go through a record in a matter of seconds as opposed to minutes and find the documentation and be able to pull the documentation that was needed. So that was a good thing. We found that out. We went through the whole process with prior authorization. Before we brought in artificial intelligence for the prior authorization, we used what we call the work list. And we found out within our organization, not all of our prior authorizations were going through or getting approved. And so we were excited to be able to turn that on. And when we turned that on, what we discovered is that our prior authorization department couldn't keep up with doing the prior authorization because we had turned on those areas that we were not doing prior authorization before. We went from maybe 100 a day to 1,000 a day that they have to go out and get prior authorization on and those things. So it impacted them significantly. And so that's where we looked at artificial intelligence and say, how can we put artificial intelligence into doing the prior authorization? So we implemented prior authorization. We implemented the artificial intelligence there, and they're doing it. It's a 30-day rolling cycle. That's the process within healthcare. You only want to be 30 days or less out with your prior authorization. We implemented that, and now it does it 24/7, goes out and get the prior authorization, gets it approved, puts it into the medical record, puts it into the record so that we can make sure that when we send it out, it does not get denied like it used to before. In our professional fee billing piece, we had an issue with being able to go again into the medical records to find where everything is located. And professional fees, there's two parts to a claim. There is the professional fee portion of it, and then there's the facility fee portion of it. We're also looking at the facility part of implementing AI there as well, but we wanted to focus more on the professional fee side of it, where we implemented our AI in there. It is now, we have no backlogs in our professional fee like we did before. They're doing them the same day they come across. We have the documentation. It's done. It's coded. It's put together. Anything that's not coded is put in the exception pile so that we make those corrections. The AI learns from that corrections. And then the next time it encounters that same, it makes that changes, and we get those out the door. In our accounts receivable area, we had to do an analysis because we had a very high accounts receivable, 122 days. We needed to analyze that, and we started out, going through humans, taking a look at it and building programs to take a look at it. Now we simply just have the AI go through and characterize and put it, and we're getting those accounts out the door also as quick as we possibly can. So in our revenue cycle, we're starting that process of the artificial intelligence. Again, we're rolling it out in our prior authorization. It's in our professional fee. It's in our accounts receivable. We're also working with our DNFBs, because if you don't have your discharge not final bill completed, you can't get it out the door. And so we're focusing on putting it there, rolling it out there as well. These are taking the things that humans do Monday through Friday, 8 to 5, and now we're doing it 24/7, including weekends. So it's really beginning to make a difference for us within this organization. So some of the high areas that we saw that we had, problems with our denials, of course, was the emergency department not getting the insurance correctly. We have artificial intelligence going in, also checking and verifying our insurance to make sure. Many of our patients come in and say that they don't have insurance because we are a level 1 trauma center. And so it actually goes out and it checks to make sure that they do not have insurance, and it puts that information in. The lab also, prior authorization, one of our high areas, it goes out and gets the prior authorization for our laboratory. And radiology was our biggest area of no prior authorization because our doctors, our providers decide what they'll do is they want it to be efficient. And so they would get a patient scheduled today and they would take the patient in to get the CT scan or something done today. They were being very efficient. The only problem with that is you don't get the prior authorization, you don't get paid for it. So we had a high denial rate in our prior authorization for radiology. So you can see prior authorization with the wrong procedures or changes, patient eligible issues, meaning they're not eligible for that type of procedure because it hasn't been approved, incomplete coding and documentation, all those things. Now we have artificial intelligence involved in that to check all of those. First priority, got to get that priority, and then checking the documentation, making sure that we have everything to get that approved. Okay, so what are the changes? We have to measure these financial key performance indicators. These are things that are critical to us to make sure that we measure. And if you take a look at on here in our AR, the things that we focus on is our AR days. Remember I said there was 122 days. We're now down to 78 days and continuing to drop that number. Our cash collection, you can see, is we were shooting for 100%. We're now collecting at 104% for the month of September, which this month we're in. We're already at 104%. We're a green dot, which means it's improving. This is where we have the AI helping out. And our DNFB's days dropped to 7 days, and they continue to drop as we push that through and making those things work. So artificial intelligence has been in place since June. Starting in June is when it actually got in place in the prior authorization area. Then we started rolling out into other areas. And so we're on a 90-day roll. So, in the areas that we actually put artificial intelligence in, that's where we expect to see the improvements continue to go. We're going to go from professional fees over to our facility fees, where we have the entire claim being clean and going out the door. We're going to go from we already measured on our pro fee side. We're now at 98% clean claim rate. We still have work to do on our facility side where we have our human intervention working. We're at 80% there, but we've got some work to do to improve on that side. So again, this is our dashboard that we go by. There are more KPIs that we measure, but these are the ones that are critical to us. These are the ones that we are beginning to focus on to see if we can get artificial intelligence in here to really improve this process as we go through.
Well, thank you so much, Robert, for a truly great presentation. I think hopefully there'll be some questions for you at the end of the next presentation. We now have Dr. William Feaster, who's going to present a little bit about himself and then his important use case.
Okay, hi, thanks. I wanted to tell people a little bit about where I'm coming from, which is Chalk Children's Hospital, which I'm a colleague of Anthony's, and it's been a real pleasure to be involved in both this course and working on a regular basis with Anthony. My role is Chief Health Information Officer at Children's Hospital here in Orange County, and my background is I've relatively new to data science for the last 5 or 6 years, but have been in informatics for 40 years and have practiced medicine for the last 40 years as a pediatrician and a pediatric anesthesiologist. I'm going to go ahead and talk today about reducing readmissions here at Chalk, and I'm going to share this screen. Is that coming across there?
Yes.
Oh, okay. I'm going to just, I'll see if it works on a slideshow. Sometimes that, is that coming across correctly?
It does seem to be coming across correctly.
Okay, great. Okay, so why am I bothering to talk about readmissions and applying data science to readmissions? Well, there's actually a couple of reasons. One, it's an issue, it's a quality indicator. If patients are readmitted within 7 days of discharge, you begin to think about, well, have I provided the right care for this patient? Is there a sort of a gap in quality? The other thing, though, is a financial one. If you are at risk for a patient population and that patient is readmitted to the hospital for the same illness, you may have a financial burden you didn't otherwise need to have. So we're doing these both for quality and for also for financial reasons. But if you look at quality, why did we approach readmissions? Well, CHOC is known for having some of the highest quality care. And we never really could make any progress on reducing readmissions. The red solid line was basically our baseline, which was running somewhat under 4%, but the national average was running just a little over 3% for children's hospitals in this particular graph. And all the things in that little box, which you probably can't see, are all the things that we had previously tried to do to reduce readmissions. And despite all that effort, we really didn't make any progress. So we decided to turn to data science and see if that would help. We published this article in 2018 on a system that we put in place for 2017 and have about 3 years experience with that now. So what was our goal? We actually did a study to build the most predictive model of 30-day readmissions under a fairly stringent set of inclusion-exclusion criteria. Bottom line here is on the far right, we had 38,000 patients that over a 5-year setting that we included in this model, with taking out oncology admissions for chemotherapy and neonates and several other criteria. And we considered sort of a bunch of traditional variables in that study. We also use something called the Rothman Index, which is an acuity scoring system. And with those variables, we were able to come up with a model that had an area under the curve of 0.79, which actually means that that model could pretty accurately predict who was going to be readmitted at 30 days. So we're pretty pleased with that, and we divided patients into high, medium, and low risk of readmissions. And it turns out that we were kind of underestimated the actual value of this model quite a bit. It actually was much more accurate than we thought it would be. We subsequently put this in a much more sophisticated data science environment and improved our AUC, the green line, actually the red line there, to an AUC of 0.8226, which is the model we're currently using in our EMR. Now, this more sophisticated model, instead of looking at like 24 variables, looked at 600 variables and found several interesting facts here. And some were actually novel variables. And that's one thing about using data science. Data science is extremely good at telling you what's relevant and also what's probably not relevant. And that people aren't always that particularly good when they develop their own models by hand. So it turns out that despite it now one of our strongest variables is the previous readmission, it really wasn't in the literature. There are really other models out there didn't take into account if the patient had previous readmissions, if the current visit is a readmission itself, if a patient had previous hospitalizations before this index hospitalization, et cetera. We use medications and diagnoses and lots of other things. So this model, in which we had the 0.82 AUC, had a bunch of new novel variables. So how do you then, okay, we have this great model. How do you apply it? Well, the first thing we did is we created spreadsheets that were published a couple times a day for our case management staff, identifying who would most likely be readmitted and who wouldn't. And they began using that to decide who they would prioritize for their work at the time of discharge. Now, another thing that was kind of interesting is this 30-day model actually predicted 7-day readmissions better than it predicted, than 7-day models that we built predicted it. And for those patients that we identified at high risk, actually 52% of them were readmitted in 30 days. For medium risk, it was 26%, and for low risk, 5% were readmitted in about 30 days, and that's for an overall readmission rate of about 13%. Now, what we decided then was, well, spreadsheets are nice, and it's nice if people could do that, but how can we integrate these tools into our electronic medical record so that everybody has the advantage of it? We are a Cerner shop, and so in our Cerner Millennium database, there's lots of data in there. We have a separate instance of that that's just the data that we can use. We pulled that data that we used for the algorithm into an on-premise data warehouse. We used R to calculate the risk, and we pushed that value of risk back into the Millennium database, and then displayed that in the Cerner EHR application. So this is so-called M-Page in Cerner. And if you pull up the patient's chart on this summary page, you can see at the top that little green circle that is the patient's pediatric early warning score, or PEW score. At the bottom is that Rothman index I had mentioned earlier. And in the middle is a R that's surrounded by yellow, and that indicates that this patient is at moderate risk for readmission, had a risk score of 0.14, and it said why was that patient a higher risk than normal for readmission. And the person who's reviewing that chart can just hover over that R and get that information. So it was easy to understand. Now, did we make a difference? The line in the center of the screen is when that was actually started to be used clinically. I think there was a little bit of a Hawthorne effect in a couple of the months prior to that, because we were actively working with our case management staff to develop this model. But after implementation, you can see with our upper and lower control limits at the top, we've now very substantially reduced our 30-day readmission rate from an average of about 12.7, and we're down to about 11% now. So I think that's kind of fun to see that kind of a response. And then if you look at our 7-day readmissions, they've definitely improved. It's not quite as dramatic as the 30-day, but we're very pleased with that result as well. Now, subsequent to that first article, we've published now 6 articles on readmission. And so in addition to this applying to the hospital, it's been a great tool for doing research, academic research. I'm going to go back to the screen here. And that's the end of the slide presentation. Okay. And so we'll open it up to questions in a subsequent session here.
Well, great. That's an outstanding presentation. We have a couple of questions, and the first question is for Dr. Sumter, and it's about whether you were able to demonstrate an increase in net income with your revenue cycle AI. We know no margin, no mission. And then I also have a question for Dr. Feaster, and it's about the principle of parsimony and whether you eliminated looking at variables that don't have independent significance, eliminated them from your model. So I think I would ask Dr. Sumter to go first. Dr. Sumter?
I'm here, David. I'm sorry, was there a question for me?
Oh, yes, my friend. The question was whether you were able to demonstrate an improvement in net income, net operating income using AI. It's no margin, no mission.
Absolutely. One of the things that was covered up on that sheet was that we have it where we do a calculation of what we should be getting for the month, what we should be collecting for the month. And as you know, we implemented the artificial intelligence. And what it showed was we're at 104%. So we have exceeded our goal for the month because, one, our clean claim rates is going out. Two, we're getting those prior authorizations done, timely, and getting the approval prior to the patient coming in, trying to get those things done. And so that was calculated based on the 27th. So we still have the 28th, the 29th, and the 30th to be able to get revenue in the door. So we expect that we're going to exceed that probably by 108%. We're going to be at 108%.
I'm sorry, go ahead.
No, I was just going to say that we believe at the end of the month, our revenue collection for the month of September will be at 108%.
Very nice. And Dr. Feaster, we now have two questions for you. One was about the principle of parsimony, and the second was have your publications played a role in engendering trust among the various stakeholders?
Yeah. Well, let me sort of try to address the first one. The data science techniques are particularly good at trying to determine relevance of data. The human being is particularly not good at doing that because you can imagine that there's all kinds of things that you think would be important, and as clinicians, we can attach importance to all kinds of things that may, in the end of the day, not have any relevance to the decision we're making, but they seem like they should. So data science techniques can, in fact, find those things most relevant and include those in our models. And, for example, there's thousands of medications in our data sets, but maybe some of them, like anticoagulants, are more relevant than whether a patient is on an antibiotic. So we have to kind of determine relative importance of data elements. And we do that, as you can see in that one slide. The presence of a prior readmission, or whether this was a readmission, was incredibly important and had a lot of power versus some of the other variables. So, yeah, we do incorporate that into our model, that we don't use we expose the model to every variable, but the data science technique itself will begin to sort through what's relevant and what's not. The second question, can you repeat that one again?
Yes. So what impact have your scientific publications had on the trust that various stakeholders have in the implementation of AI?
Yeah, well, this isn't something that's telling people what to do. This is just augmenting their, intelligence augmentation, if you want to call it sort of IA instead of AI, where we're just giving them additional information they didn't previously have the ability to collect themselves and calculate a risk score. So it's pretty easy to get credibility when you also then publish your results. And also the publications, we've included a lot of key players in all our publications. So it's just not Louis Akremoefa and myself doing the publication. For our work in readmissions, we included the team actually doing those readmissions, hospitalists, et cetera. So you get more credibility when you engage other people in the actual publications. So we've found that has a lot of value. We also, within the organization, a lot of the physician leaders meet with us when we do projects with them in data science. So I think that also gives people, more credibility, gives us more credibility with the physicians.
Well, that being said, I want to thank Dr. Sumter and Dr. Feaster for two outstanding presentations, and I'll turn it back to Anthony Chang.
Okay, we will have a 30-minute comfort break, and we'll come back to a really robust panel discussion on some of the aspects of AI and ethics and everything else. So we'll see you in 30 minutes. Thank you. Welcome back, everybody. Hope you enjoyed your comfort break. And we're so excited about this session because it's focused on ethics of AI, which is a very important part of everything we do, especially given what's happening around the world right now. So I'm so privileged to be introducing to you Tom Lowry, who is the National Director for AI, Health, and Life Sciences at Microsoft. And we are blessed to have him for our moderator for an all-star cast to talk about AI and ethics. So Tom, welcome. Tom, you're muted.
You know, someone should invent some artificial intelligence that keeps that from happening. Anyway, thank you, Anthony. It's great to be with you again. And I was just saying, if you could lip read that, it's always a privilege to be part of AI Med's programs, but it's kind of humbling to be presenting and then having such a great, deep panel to hit this topic. So it's great to be here. So with that, I'm going to go ahead and jump in if that's all right. And with that, I'm going to take a second. I assume I am now transmitting on my slides. So anyway, it is a great privilege to be with you today. What I've been asked to do is basically throw out a few things to level set or set up the context around which we're going to have a great panel discussion. So when it comes to the ethics of AI in health, and at Microsoft, we have a broader view where we actually focus on responsible AI for health. The real question is, how do we create value that benefits everyone as we move ahead in all aspects of artificial intelligence? So the premise of the conversation today and the things that I would ask you to think about start with this. AI in health will be a force for good for all people or for some. And the real issue is we all get to decide. This is not a topic that we leave to the data scientists, to the programmers, to the clinicians or ethicists. This is something that we all should be a part of when it comes to the conversation of moving AI head forward in a responsible fashion. Anyone following the topic knows that AI is evolving at warp speed. Just in the last few years, we've seen things reaching human parity, such as vision, speech recognition, reading, translation, speech synthesis, language understanding. Almost on a monthly, quarterly basis, something else is skidding across that finish line for human parity. So as AI starts reaching the capabilities of what humans can do, the real question before us is, what are the societal implications of the technology we're creating, especially as it relates to the art and science and commitment of healthcare and medicine today? So in the real world, I think we all know AI is not neutral. These are two of one of my favorite books, including Weapons of Math Destruction. But there's a lot of data, there's a lot of articles that suggest that in the real world, it's not neutral. Now, we've seen just recently, and particularly in the last year, a number of studies and articles coming forward that's documenting some of the issues around things like racial bias, skewing everything from heart surgery to births. There was a groundbreaking article in June from the New England Journal of Medicine looking at things like race correction and clinical algorithms. And all of this data is starting to strongly suggest that many of the biases and inequities in the real world are starting to cross over into the digital world as we increasingly make use of things like these algorithms. So it's always important to point out, to the best of my knowledge, that there's no Dr. Evil behind this. No matter what you may believe the Russians are trying to influence, I don't think this is one of those things. In reality, bias and unfairness often comes from things like the value and biases of those who create these things, the data we use to train algorithms, and how data and AI is actually used in practice. So many times what that looks like when it comes to fairness-related harms, AI systems can fail to provide the same quality of service to some people as they do others. They can unfairly allocate opportunities, resources, or information. They can reinforce those existing societal stereotypes or over or underrepresent groups of people or even treat them as if they don't exist. So one of the most important things for all of us to think about is how AI-driven systems may create unfairness or harm if we as healthcare professionals don't understand the limitations and the accuracies of such systems. One quick example that really caught my attention a while back is an algorithm used to decide which patients receive additional health services. This is a situation where patients were already going through the health system. This was an algorithm that determined which patients would go on to deeper, specialized, more expensive care and which ones would not. So this was an algorithm that identified patients as needing more care. The results were Black patients were moved ahead at 18%, while white patients at 82%. Here was the issue. The algorithm correlated health spending with health status. Past health expenditures were used to predict risk of worsening health. In America, white Americans have a much higher health expenditure than Black Americans, even when their health situation is identical. So in this case, if the algorithm did not use that, which is a correlational bias, the true proportions would have been more like 46 and 53% respectively. Interestingly, and this was written up in Science Magazine last fall, this is an algorithm that was used to risk rate over 100 million patients. So this isn't an isolated incident. This was something having very broad impact on the progression of care for many patients. So what we're here to talk about and look at are really what we call principles of responsible data and AI. At Microsoft, we have defined 6 basic principles that we consider an important part of the dialogue when it comes to creating and managing responsible and ethical AI. So with that, we're going to go a lot deeper on these and other things. And I'm just going to wrap up by saying that there's so much more we're going to be talking about in a second. If you want additional resources, there's a book that Microsoft created that's an ebook called The Future Computed. It is not a cookbook, but rather a framework that helps organizations understand and create their own policies for dealing with responsible AI. It's freely available. Go out to any search engine, type in Future Computed and Microsoft and download a copy. My newest book from HIMSS Publishing also goes much deeper into this and other issues. With that, I'm glad to get my stuff out of the way because I'm very excited to introduce our global panel for responsible AI. So we have with us today a really great group, starting with Dr. Alberto Tozzi, who's the Chief Innovation Officer and Research Area Coordinator for Bambino Gesù Children's Hospital in Rome. Alberto wins the award for longest virtual distance travel for today's meeting. I think it's about 8 o'clock in Rome today. Michael Dragalis, who is the Chief Data Scientist at Penn Medicine. Brian Bennett, Executive Director of Healthcare in the Center of Excellence. Sarah Gerke, who's a Research Fellow at the Petrie Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. I'm sure Sarah has a very long business card with that. And finally, Lynn Van Arsdale, who's the Engagement and Delivery Manager of MI10. So I'm going to stop sharing my screen and let's pull up the panel and look at where we are. And first of all, welcome everyone. Thanks for joining us. It's great to have such a great panel available today. So with that, what I'd like to do is open it up and see if there are starting questions from the audience that we might want to get started with. So questions from the audience for the panel. Let's see what's out there. Okay, well, while everyone's thinking about their questions, let me get started with a question or two. So, Alberto, let me turn to you first. When I think about things, and I look at what's happening, particularly in medicine and clinical decision support and other things, are there ways for physicians and patients to actually play an active role in the development and use of AI applications? And I often wonder about whether it's physicians or consumers and kind of their level of digital health literacy. But I mean, what are your thoughts on the involvement and the role of physicians and consumers?
Thank you, Tom, and welcome everybody. Well, let me give you a couple of perspectives. We have been discussing a lot in the last years about the role of physicians in artificial intelligence. First thought is about data. I'm a pediatrician, but I'm also an epidemiologist, and I always think about the value of data. And sometimes the discussion we have is that data are not neutral as well. It's not about artificial intelligence. We collect data, clinical data, that might be biased. And this is one of the things that we always have to keep in mind, because if we don't design correctly the process for feeding AI, we will have problems. We will have bias. We will have problems with equity. And all the things that you brilliantly described will come out and emerge. The second thought is about the education path of clinicians, because I never studied anything about artificial intelligence, and I was never updated about this discipline until I met several good friends. Many of them are in this panel as well. And I was shocked when I understood that artificial intelligence has such a power. It was coming immediately to my mind that one of the problems would be having clinicians understanding what's going on with AI. I don't want to say that the clinicians should be able to develop and make programs, but they must understand and stay side to side to people developing artificial intelligence programs. Otherwise, it will be a problem, because this is absolutely the case for a multidisciplinary approach in which not only clinicians and developers, specialists, data scientists, I would say, but also patients should participate in developing the right process at the right time. That's my personal feeling, and I think this is a very long discussion.
Yeah. Thank you. You already generated another question. I'm going to come back to you in just a minute. So, Sarah, let me turn to you. I touched on my very quick run through some slides about AI not being neutral and ways in which things like bias creeps in. I mean, it's a very broad question with perhaps not a lot of easy answers, but I mean, how does one best mitigate bias? And are there standards out there we should really be looking at or developing?
Yeah, thanks, Tom. So I think this is like a very difficult question, which we probably haven't figured out completely yet. But I think we really need to see an AI as a complete system. I see it more like a life cycle where you need to start from the collection of the data until the post-marketing of those products. And so, like Alberto already mentioned, you need to start and have already like clean data, which you feed into the algorithm, but you also need to make sure that the algorithm itself is not exhibiting bias. And then even if we manage to bring the product on the market and it is at that moment safe and effective, if you really want to realize the full potential of AI, they should be actually being adaptive. The algorithm should be adaptive so that they can learn from new circumstances, data, etc. And then it gets even more complicated, because then you need to think about how do you actually make sure that those products remain safe and effective. So you actually need to continuously monitor those products. And then I think the next layer is what Alberto also mentioned, that also the healthcare professionals, the physicians, they need to understand what AI is, and if they cannot, if those products will be deployed more and more in the hospitals, they also need to explain, or being able to explain to the patients, what is AI. And so I think we have a lot of things a lot of challenges we need to figure out.
Yeah, no, I love your answer, including the whole importance of transparency in what we're doing. So Michael, I'm going to pose a question to you that kind of comes from what Sarah just set up. So, we've got a lot of machine learning solutions being deployed in healthcare today. I mean, increasingly, it's becoming a part of the fabric of healthcare today. So, and to Sarah's point, we have many machine learning models that are continuous learning models. They're constantly changing. So the question is, machine learning models have the ability to drift and break over time. So how can patients be assured that every day these systems are running accurately, safely, and fairly? They may start that way, but again, with drift, with continuous learning, they're going to change. So how do we be assured that it's doing what it's supposed to do?
Yeah, no, that's a great connection to Sarah's answer there. I think, we're very much in the early days. We're very much in the first generation of models being deployed in healthcare. And the reason for that is, there haven't been a lot of, press coverage around health systems falling on their face when these things break. The truth is, the practice is not that these models are monitored. The practice is kind of expecting these are blinky lights that you just turn on and they keep working. And there needs to be a sophistication and culture built now and going forward to build in these expectations and some kind of external assurance that these systems are correct and safe. I'm reminded of the early days of a passenger flight. If you Google, there's a picture of, it might have been the first one, where there's this old black and white picture of planes taking off, and there's someone actually standing on the wing and like 3 people, sitting in the back, and there's people running like really excited. You contrast that right now with, plane flight, and when there's an accident, there's a whole process to dig into what's going on. I think right now people are just excited when things are deployed, and there's a sense of success. There's press releases put out there, but really what you need is to build a culture of engineering or HROs, highly reliable organizational structures within health systems, to ensure that there's monitoring and improvement in each of these processes. And so I've been at Penn for 6 years. We're deploying models, and I come from the defense industry and kind of took that into our work, where we have daily on-call sessions and ways to ensure these things are running. But definitely it's a place where we need to become more mature to make sure that we're keeping patients safe.
Well, so on that, it's interesting that you would mention things like high reliability organizations and, those things that have been in things like the airline industry for decades. And I know there are many organizations in healthcare that have been adopting that. But a lot of that kind of moves us from, looking at just the technology. And Brian, I'm about ready to pose a question to you. But, so we have all this great technology, and it's proven to be able to generate, highly correlated values that help us predict things. But then they have the ability, as Sarah and Michael pointed out, to change, break over time. They have to be monitored and managed. So in that regard, Brian, I guess my thinking and my question is, we're most always talking about the tools and the algorithms, but when it comes to, well, how do we actually bring them into real organizations, have them drive value across the enterprise, not cause harm? I mean, what are your thoughts for the importance of things like process improvement, training, and really the role of leadership in any healthcare organization to really make this thing work? I mean, what are your thoughts?
Well, I think, on the process side, you have to make sure that everyone understands their roles in the gathering of the data and the input of the data. AI requires a lot of data. And if it's not, extracted and transferred and loaded properly, it's going to, you're getting garbage in, garbage out, the same typical analogy. So that's important to make sure the processes are proper there. People have to understand what their roles are in the whole process too. You can't have, if you don't provide proper training, you're going to have people, not recording or not accessing information right, or not entering the information properly. And one of the biggest problems that I've seen, we did a study on this a while back, just on analytics in general, is one of the biggest challenges in implementing just basic analytics was the lack of leadership. Because so many of the people who are in the C-suite or in the other executive positions don't understand how analytics is going to actually affect them and be useful in the organization. So, having that leadership and understand, what analytics can do for them, what AI can, how it can be implemented, and making those important decisions. Because hospitals systems are very siloed in nature, and somebody has to decide who owns the data, where's the data housed, and all this other kind of stuff. And that's where it comes to the executive has to make that decision there.
Yeah, great. So, Lynn, I'm going to pose a question to you in just 1 second based on what Brian and others said, but I'm just looking in the chat window and there's, some questions and comments about, there's a lot of talk where we can outline the issues, but what are the ways in which, we can actually go from the discussion to actionable guidelines and making things, really true up with the things we know are issues. And I can start that and anyone can join in, but I know Anthony put in the chat window some resources, but I think that is the challenge. And back to, we're kind of all responsible for this, where we have to move from identifying the issues and the problems to putting in place things that really help us all develop those frameworks, those guidelines. So it's not just performing as we think it will, but it's performing in a way that produces value for everyone, that is at least mitigating bias, if not eliminating it. And so I know there are many others. I mentioned at Microsoft, the Future Computed was one of our early works. Anyone that's interested in learning more about some of the things we're doing, including actual guidelines, checklists on developing algorithms, we have something called the Office of Responsible AI. This is where we develop standards that we live up to for anything we're producing. And we've gone beyond that to say, here are resources that others can use as they're developing their own approaches to AI. I can't speak for the American Medical Association, but I know they were some of the early adopters of policies that their group adopted to at least call attention to this. I know they are looking at a number of things because they are looking at, again, how do we make the best use of AI in a responsible fashion? And then some of what our speakers have already said, looking at what's the role of the tool of AI and what's the role of that human, that knowledge worker, that clinician. So maybe we can hear more, but Lynn, I want to turn to you for the things we've already been talking about, because I'm sure you've got all the answers now, but no, seriously, what are your thoughts on top actions we should be thinking about to ensure that AI is in fact being used ethically?
Well, that's a really good question. I think that some of the data issues we had discussed previously are really key to coming up with ethical processes, standards, et cetera. So a lot of the data that we get is qualitative data. It's often self-rated data, and different raters will have different perspectives, and that may introduce bias. It may introduce ways of seeing things that are unexpected. So two things come out of that. One is to look at inter-rater ratings to try to figure out if there might be those biases in the populations that you're using for your models, for training especially. And then the second thing is, if there are surprising things that come up, which often there are, dig a little bit. Make sure that the things that don't pop out at you as making sense aren't introducing some sort of a bias or have some erroneous or biased data behind it. And then the last thing that I'll say is, in terms of the data that you use, the best way to make sure that you're getting something representative is to have a larger population from which to sample when you're picking your training data. And that really involves a lot of what we're up against with EHRs and HIEs, trying to interchange data. You have to have good standards that allow you to match data along the most important parameters, make sure that they go into the model the correct way, and then also be open to federating. And I know that Brian talked on this a little bit, that you have to break down those silos, not just within an organization, but across organizations, and look at ways to federate data so that you can keep proprietary things proprietary, and then also be able to share what could be important to making your models work properly.
Thank you. Great response.
Do you mind if I just add on to what Lynn was saying, just in a
Michael.
practical sense? And Lynn, I think that's really great. Just at Penn, we've been, particularly since June, trying to figure out how do we build kind of this ethics audit into our work. And a lot of it starts from understanding what, we're intending to build a model, but what is the current system bias disparity, health or healthcare disparity in the system? And so we go through this process of looking at that piece. And then if we intend to build a model, we build the model and look at the disparities there. And if we don't find any, we continue on. If we find some, then that's the surprising things. We have a process to kind of expand our workflow, expand stakeholders, and look for antecedents to the system that we originally looked at to dig into. So we're trying to processize those things and bring all the stakeholders into play. And we do have, template reports, but a lot of it's qualitative, rolling up your sleeve and getting down to root cause.
Great follow on, Michael. So I'm going to take that, and I'm also looking at the chat window. So there's a question comment from Suresh. How did the disparities happen with those AI models, and what went wrong? And perhaps I can frame it, and then we can see what you have to say. What's interesting oftentimes is those disparities happen because of simple things that we actually could, in fact, understand and manage. So in several cases, and again, I highly recommend an article from the June 20th issue of New England Journal of Medicine. And if you're listening, if you want, just email me, I'll send you a copy. But it points out a number of issues when it comes to what they call race correction and algorithms. And there are times like the example I cited. It's a correlational bias where anyone who really understands healthcare economics, at least in the United States, knows that the amount of money spent does not correlate to many things, including worsening health. Where sometimes it's transparency, as Sarah mentioned, where there are algorithms created and someone puts something in the predictive capabilities that is kind of hidden, but a logical person understanding that clinical process would say it's not right. And finally, I have seen algorithms developed and put in the wild in healthcare that produce high correlational value. They actually produce good in terms of improving overall quality, maybe even reducing costs, but they haven't been stress tests for things like equity and fairness, which is to say, so imagine we've got a situation where we've created an algorithm to predict adverse events before they happen within patients to keep them out of ICU and being coded. So let's say I've done that, and I've proven that I can reduce those adverse events by 40% in a hospital. So it's a quality improvement and not going to ICU. It's a definite cost effectiveness measure. So I think everyone would say it's a win, but that's a statistical average. If I told you that average was based on an algorithm that was 3 times better at predicting and keeping white males out of ICU than Hispanic females, is still producing overall quality, but would that be okay? And I'm posing as rhetorical. I'm not going to give you my opinion. I have one, but those are the issues I think we're here to not only identify, but figure out, according to not only the panelists, but the things coming through the chat, what do we do to first create awareness, and second, create those guidelines, those guardrails that Michael and others are talking about. So let me stop. That was my soliloquy. Let's see others from the panel, maybe starting with you, Alberto.
Well, I think we have an amazing opportunity. That's my my thought. And recalling what Lynn was saying, I think that getting back to data is not only essential for giving the real framework to AI algorithms, but it's also something that will make us thinking of the data that every day we deal with electronic health records. So data quality is never a resolved issue. And I think this is something that gets back to the initial point that we should address absolutely. And this is good, because otherwise we feel like we can give to AI the power of dealing with any issue. And this is not possible simply. The second thing is that connecting the dots and connecting the data, connecting the databases coming from everywhere potentially is the second option and the second opportunity. I think that we must learn from the collaborative approach that having data pulled together will be absolutely crucial for scaling up the power of AI and thinking of changing the health of everybody on the planet. That's a simple rule. I learned that and I discussed that with a lot of people, and I hope that I will be dealing with this principle not only in my hospital but within a network of hospitals and other places that are willing to do this way. And this comes back again to the role of clinicians, because I think that beside the power of AI algorithms, and we know that they can allow us to pilot a plane or to do very complex things, but AI is not something automatic. AI is something in the hands of physicians and sometimes also of the patients. We should get the most advantage that we can from this collaboration. And I think this is the very lesson that we learn when studying AI and the relationship with humans, I think.
Okay. So we've got about a little less than 10 minutes. I don't know that the panel's been challenged enough, so I'm going to pose a question, and Sarah, I'm going to start with you. Here's the question. If a clinician's using AI to support decision-making in the diagnosis and treatment of a patient's condition, so it's real, it's being used for diagnosis and treatment, and something goes wrong, who should be held responsible? Is it the clinician? Is it the algorithm and the developer of the algorithm? Is it the organization that sanctioned the use of that algorithm and bringing it into that hospital or clinic? Sarah, let's start with you.
Yeah, so this is a very good question. And I actually wrote a paper with two of my colleagues, which was published in JAMA, about that question. And we looked at the medical malpractice and whether a patient would actually be held liable under current law in the US, under tort law. And I think right now, the AI itself is not the standard of care yet. And so a physician, to not being held liable, always need to follow the standard of care. And so if the AI is recommending a treatment which is not the standard of care, and the physician following that AI, and then damage or harm to the patient happens or occurs, then right now it may be likely that the physician may be held liable under current law. But this is like a space which we really need to watch very closely, because that can change over time, and the AI can become the standard of care. And when that's happening, then it's actually the case that if the physician did not follow the AI, then and harm occurs, that actually the physician will be held liable. And also one needs to say, like, it goes, if something like that goes to court, there will be also a trial. So the jury will probably decide, and then it will be also interesting to see whether already now the jury would decide that it is okay that a physician relied on an AI. So this is like a really interesting area right now, and it's like a huge ecosystem of liability, because that's just like one picture, the physician, but you also have product liability, and the developer. You have a hospital who actually bought the AI and wants the physician to use it. So it's like a very, from a legal perspective, very complicated questions of who should be liable. And then you also have transparent AIs, but you have also black box AIs. So should there be a difference between the two of them regarding liability, because the physician probably cannot even look into the AI and knows how the AI reached the decision. So this is still a space where more work needs to be done.
Yeah, there's a lot of effort that will go into that, and again, we're all very early in the journey. So we've only got a few minutes left, and what I'd like to do is this. I'm going to go around to the panel. If there's one parting thought or recommendation that you want people thinking about when it comes to ethical AI, and either helping to define the problem of what people should think about, or one thing that you would say we should be doing, I mean, what are your simple thoughts in 60 seconds? And Lynn, I'm going to start with you. And I think you're on mute.
There we go. My cursor wouldn't move. I think that the points everyone has been bringing up really leads to the fact that we are individually responsible for what we can try to affect and know. I think it's important that all stakeholders should understand the model and the data that that's behind the tools that they're using. And again, address any concerns, really dig where they think there isn't something that they quite understand. But on top of that, you also need to have an escalation plan so that people at all levels of an organization or in any organization that sees something that might be unethical would have a way to report it and have people follow up on it. I think that's probably true with any ethics that you would introduce into an organization. There has to be a clear escalation plan and one that enables people to bring things forward.
Great, thanks. Brian, I'm going to go to you next, 60 seconds, and then Sarah, you're going to be after Brian. Brian, parting thoughts.
Yes, a couple of things that I'm very concerned about is one, we have to make sure that the information is given to the clinician at the time he or she is in front of the patient. I've been to so many conferences over the years, and they're talking about, oh, we run this overnight and get the information to the doctor the next day. That's not going to be acceptable. It has to be right there when the doctor is talking to the patient. That's one. Number two, at least for now, we can't tell the doctor what to do. Okay, we have to give the doctor options. So the AI says it could be one of these three things. One's a 70% chance probability, one's a 20%, one's a 10%. The doctor may have already checked for the 70% one and said, no, that's not the case here. And so he or she has to go down to move to the next one. So you try to sell to the doctor, say, this is going to tell you everything you need to do. The doctor's not going to accept it.
Great, thank you. Sarah, 60 seconds, and then Michael, I'm going to come to you.
Yeah, so I just say probably as a sum up, I think stakeholders in total should practice ethics by design, no matter what the law says, and thinking about really all kind of questions from bias to transparency, how to implement those products. And I think one can already mitigate from the start those problems, at least as much as possible.
Great, thank you. Michael.
Yeah, thanks. I think, one thing to remember with AI is it is just an engineering tool. It's like what we call BPAs. These, you can just define some logic when creatinine goes above some threshold. Right now, there's no difference. There's some accounting for how these models drift over time, but they don't have general awareness of themselves where some ethical structure can be applied to the AI system itself. And I think what we need is when there's new protocols deployed in healthcare systems that are informed by data, health systems need to increase their rigor and accountability when doing that work. And sometimes it'll involve machine learning, sometimes it won't, but the clinical work is the same. And I think that's the important thing to remember and take away.
Thank you, Michael. Alberto, you have the last word.
Oh, my last word, beyond all the things that we have discussing was amazing. There are a couple of things. Education of clinical doctors, this is essential, but I'm recommending one single thing, bringing the patients to the table for developing AI tools, because I think they can make the difference, absolutely. And this is not about their competence or their ability to, again, to make programs for AI, but to let us understand what's right and what's wrong.
Awesome. Well, I want to thank everyone. So great panel, Lynn, Brian, Sarah, Michael, and Alberto. We easily could go on and on and on. It's such an important topic. I want to thank Anthony and Ahmed for really making it an issue and getting us on the agenda to hopefully further your thinking and your motivation to take action. With that, I'd say thank you so much. And Anthony, back to you.
Thank you, Tom, and for such a masterly deed as the moderator, keeping on time and getting everyone involved. And I know for a fact that's not easy. And thank you for your wisdom too, as always. So Tom, thank you. And also thank you, panelists. Look forward to getting to know you more. So we're going on to the second to the last session, which is another panel discussion on, so we talked about ethics. So it's kind of a nice segue into now what? Now, not that we have figured out the ethics, by the way, but how do we implement and how do we adopt a strategy for AI in the healthcare system? And I think it's more timely than ever before that we get this right. And there's a sense of urgency for a change. So to lead this session, again, we have another all-star team, and it's going to be led by a moderator who I see almost every day, Matthew Gerlach, who is the COO of Children's Hospital of Orange County. So Matt, take it away.
Oops. There we go. Can you all hear me now? Yes, good. Okay, great. Good afternoon, I guess. I'm Matt Gerlach, Chief Operating Officer. I am with CHOC Children's here in Orange County, California. Been here for 7 years now and have had the distinct pleasure and honor, really, to work with Anthony to support the tremendous leadership he's provided for innovation, both here locally as well as nationally, and I dare say internationally. So delighted to be here with you today. We only have 40 minutes, and the topic today is to focus on key requirements for successful implementation of AI, how we get started, what are some of the cultural change issues that folks work through, and I'm joined here by a distinguished panel of individuals. I'm going to do a very, very quick intro on the bios of each of you, and I apologize if I leave things out, but since we only have 40 minutes, I want to make sure that we get a chance to really dig in. The first question I had for myself was, how do I introduce such a distinguished panel and who goes first? So I decided to make this alphabetical, so that way we can all be on board. First, Dr. John Brownstein, who's the professor of biomedical informatics at Harvard Medical School, is the chief innovation officer of Boston Children's Hospital. He directs the computational epidemiology lab, and robust clinical decision support tools to improve quality outcomes and control costs. So with that, I'm going to take a deep breath and kick us off with some questions. I'm going to actually go in reverse order here. I'm going to start actually with Dr. Suresh. And Dr. Suresh, as a emergency room physician, I understand, along with leading clinical informatics, you're interested in business intelligence tools, particularly enhancing provider, patient safety and satisfaction. Could you talk a little bit about the challenges and strategies for you in implementing AI in these areas at your organization?
Sure. Thanks, Matt, and good afternoon, everyone. I'd like to add one more degree that I have, and most of you have. It's FOA, Friend of Anthony. I think it's important to mention that. But great event so far. I've learned so much in the last few hours. Going back to your question, Matt, I'll put on my hat as an emergency physician. And traditionally, when we look at a patient, and let's say it's a child with suspected sepsis, I have my pretest probability, in 1 or 2 minutes after seeing the child, and then I, get a history, get some tests, reassess the patient, and then it sort of goes up. And at that point, if I have AI-enabled tools, which will significantly increase my suspicion one way or the other, that's a very practical application that's going to help me, my patient, and my peers, because I can explain it to them that way, and show a very clear return of investment. I'm not talking finance here, on emergency department throughput, on efficiency, etc. So it's sort of an oversimplified example, but having these kinds of use cases really gets clinicians and patients and trainees and administrators on board to even have a discussion on how much should invest in AI, what should be our parameters be, etc. Thanks.
Other thoughts on that question? Anybody else? Maybe Dr. Kumar, you can speak a little bit about the work you're doing in breast cancer and trying to identify ways to use AI for breast cancer detection.
Thank you for that question. Now, it's interesting that within the remit of all our specialities, my initial journey into AI had actually started because I'm a breast screening specialist, and because a need over a period nearly 2 years ago rose where we had a workforce issue where you have fairly stringent deadlines to meet for the screening mammograms. And that presented opportunity to look at other ways of meeting that demand when we were short on consultant colleagues. At that point, we decided to, well, what are the other options? We had skill mix where we could train up our radiographers, but at that point, AI had entered the clinical picture and different companies had started looking, especially in the field of breast cancer, because it's low-hanging fruit. It's a screening setup. There are multiple vendors in that space, and will have improved help with the lack of workforce that we know, especially in the UK, that exists for the fact that breast screening mammogram needs to be read by 2 consultant colleagues within a 2-week time frame from when it's taken. Interestingly, as I started looking into it, we realized that on a hospital level, we weren't actually geared up to see how AI comes into the clinical picture, including all the different stakeholders that actually need to be part of this. And this is something we actually realized quite early on. So just in our journey, the way our approach was that actually let's first get our house in order as to how we're actually going to even look at operationalizing AI within a hospital setting. And to that end, we actually set up an AI working group. And the premise is essentially to actually define our vision and strategy to actually look and identify clear-cut priorities. What does success look like if we integrate a particular AI? It doesn't just have to be breast cancer. That's just how I started my journey. But what it led us to is that have an approach that you're trying to solve a particular problem, and that the AI will help you solve that particular problem. And as long as you can demonstrate value and cost saving, there was going to be benefit to using AI. After that, we just got the right people involved. So alongside getting our senior leadership in working alongside clinicians, we had our research and development, our information governance, our PACS team, procurement teams, contracts teams, and HR all come together. So everyone was sitting at the same table talking about the same metrics together before a decision got made. So, and it's with this sort of infrastructure that we started looking at, well, how do we start looking at the different things that we may use AI, breast cancer being one of them, then actually looking at the metrics that how AI is going to improve performance. And as I'm sure all my colleagues will agree, there's not actually that much research available right now to show the intended benefits in clinical practice. There's a lot of research for an algorithm and softwares when they work in a research setting, but right now a lot of work is underway to actually show that there is benefit and value to a service, to a department or a hospital. And once we have that in and actually learn how to implement it within a workflow process, to then validate that data and then disseminate it.
Dr. Fisher, I saw you nodding your head as she was speaking. Could you speak maybe a little bit about efforts with AI? Have you also set up have a committee or some kind of a working group that you've pulled together as you're looking at the work that you're doing, particularly on the cardiology side?
Yeah, well, as is typical with the NHS, we have multiple committees that frequently work at cross purposes in order to try and deal with these things. But certainly what we do have is we have things that are particularly related to digital innovations of all sorts, and AI forms, I think, currently a relatively small but significant part of that. I think Amrita quite rightly mentioned, you know, the importance of planning and having the right people on board and having the right sort of system. Perhaps, therefore, I might like to mention the importance of culture. One of the things that I think I've learned in the years that I've been involved in trying to deploy all sorts of systems, most of which have been not fall under the umbrella of artificial intelligence at all, have been much more prosaic than that, is that you can plan all you like, you can have the best system that you like, You can have the senior leadership on board, which you absolutely need. But if you get the people side of it wrong, then it doesn't matter what you do, it's going to go down in flames. And I think that is particularly true with artificial intelligence, because although it's very exciting, it's also very unfamiliar, and that produces particular barriers. I think the last section was particularly interesting from an ethics point of view, because I think people have some very legitimate worries about ethics of all of this. And that feeds into the bigger question of trust, which is partially about ethics, but it's not just about that. It's about, will this actually make my life more miserable? Will it downgrade me as a clinician? Will it even replace me as a clinician? I mean, I think we're a very long way away from that. I think as doctors and people in this field, we're one of the safest professional groups at the moment. But people do worry about that. And again, if people don't trust what you're trying to do, then they will sabotage it. And, it doesn't matter what you do, your workforce can if they choose to do so. And I think the final thing that might perhaps be worth mentioning is, if you like, how it's presented. So another thing that I've learned is, again, you can have a great system that everybody agrees brings genuine clinical benefit, and which is, safe and ethical and all the rest of it. But if it makes their life harder in order to actually use it, then again, it won't work. And particularly that's true in the very high intensity areas. So for instance, in areas like emergency medicine and so forth. Again, we spend a lot of time trying to put the system absolutely under the clinician's nose. Because if they have to go 2 clicks away from what they normally do in order to get there, it doesn't happen. So I think perhaps those are my initial comments about what I think is really important in terms of deployment.
Thank you, Professor Fisher. I'm going to turn to Carl Hightower now with multiple systems in place. Can you talk a little bit, just dovetailing a little bit on Dr. Fisher's comments, is really what's the burning platform? That's classic change theory talks, Cotter and others talk about, you need that burning platform first. What's the burning platform for AI right now that really can get everybody rallied, particularly in an organization like yours where you've got multiple organizations and multiple entities? Just curious if you speak to that a little bit.
So when we've approached AI, we look at it as a system intelligence. It's a tool designed to reduce friction points. So if you look at where friction points exist within different workflows, whether it's clinical, whether it's operational, or whether it's actually getting to know and understand a person, whether that's a patient, a doctor, or any other person within the system, we've really looked at more of a design thinking approach of as much in the workflow as possible. We have different review boards. If it's clinical, it instantly goes another path because we have to have clinical leaders totally and completely buy in, because they're the ones that are going to have to sell it within the community there. And as we've gone through, we look at the imaging has really been the quickest adopter. Being able to point out things to bring it back up to radiologists. Viz AI we put in order to really reduce the treatment time between recognition of an aneurysm to treatment from there. But a lot of this is machine learning that we've had into, like you said with the BPAs, is really just to make awareness. It's still on the clinician to make that decision, but we're going to point out some things, and their teams have had a say in what's going on behind the scenes. So it reduces just a lot of the hard work of having to compile all of this information down, and it really just reduces it quickly for them to make that decision. And that's, I would say, the number one thing that we looked at is how do we just make things faster and easier within the certain frameworks. A person could probably do it, but it's not within the time and the flow of which they're forced to work.
So that becomes kind of a way to separate the wheat from the chaff, as they say. Dr. Fisher's talking about, boy, if it's harder and it's making more work, that's obviously not going to fly. But if you can really bring value back, to the table and demonstrate how AI can bring value and make things easier. That's really where the payoff is, and I think that's kind of goes without saying. But
time is the most important thing, and if you look at it, it's that relationship, that one-to-one relationship, and how do we make that more advantageous?
I'm going to turn to John now, Dr. Brownstein. With this whole idea of payoff again, and particularly with your epidemiology background, everything that's happening, everything in hospitals and healthcare right now is all COVID all the time, 24 hours, right? So is there an opportunity at this time right now with what's happening around COVID and our response to COVID to make a stronger case for AI? And if so, how?
Well, I mean, broadly speaking, COVID has made a strong case for sort of digital transformation, and so much of what we've put into place as an organization, the resourcing behind people that can help around implementation, but more importantly, change management, all sort of function to help push us down this sort of AI transition. I think there are some good examples where AI can be super helpful in COVID. I'm deeply involved in a wide range of public health projects, but on the clinical side, we've implemented chatbots and decision support tools to help both our patients make decisions and whether they can come in or seek telemedicine visits, or to our employees who have used some of these tools that we've built to decide whether they can come into work. I think more importantly, I think it's recognized at a broader scale the opportunities to bring process automation into play in our institution. I think, as the other sort of panelists have said, I think the easiest places have been sort of in the operational and financial management. And we've seen a lot of success already in things like prior authorization, a lot of work around operational efficiency, occupation, the ICU are high sort of cost environments where we can bring AI to help really understand sort of the optimizing sort of use of those environments. Also things like call quality monitoring and automated texting, credentialing, all the sort of repetitive tasks that previous panelists have said are so ripe for transformation. Those are the easiest places for us because we are in a pediatric environment. And so some of the clinical side does require a lot more work. And we do have some big projects and sort of imaging and food allergy risk prediction, a bunch of things, but those things are not as generalizable, so they've taken much longer time for us to sort of bring into the fold and think through sort of a broader vision as opposed to some of these one-off efforts. But I would say, just to answer your question, clearly COVID has been such a dramatic force of change at this organization, both recognizing where we can support patients now, but also recognizing where costs need to come down. So yeah, I think there's a lot we can talk about specifically around pandemic response.
Thank you. I'm going to turn to Dr. Lin. We've got some questions that are popping up, and I want to make sure people know I'm not forgetting them. I want to make sure that all of our panelists have a chance first to speak, and then I think we'll circle back and speak to some of the questions that have popped up. So I'm going to turn to Dr. Lin now. Dr. Lin, in your role as the Chief Research Information Officer at Nationwide Children's Hospital, where do you see the intersection of research and AI happening? Is there an embracing of AI in research? Is there work to be done around acceptance? Is it a natural transition? Is it rocky? What do you see as some of that intersection between AI and use of AI in research?
Matt, thank you for the question. I think the key here is to integrate these two parts together, the research part and the clinical care part. At Nationwide Children's, we started this journey about 3 years ago. We see it's a very productive route going down this road. Originally, my role started as a Chief Research Information Officer, largely on the research side, 6 years ago. Starting 3 years ago, our team expanded our data science and our AI service to the whole enterprise. And at the same time, we created a governance committee to determine the priority of those clinical projects. Right now, we see the usage of our AI and data science group purely clinical care or administrative projects, maybe 60 or 70%. Research, 20 to 30%. When I started, it's almost like 100% research, 0% clinical practice. So over years, we really flipped this ratio, and we found it to be very much helpful.
Thank you. I'm going to jump back. We got some questions here, and I'll always, I think we can jump in. The first question really is for Dr. Kumar. It says, using AI for image recognition in mammography has been criticized for engendering extra image-guided core biopsies with false negatives and even extra excisions for lesions whose biologic behavior don't justify it. How can we address these concerns? So there's a link between AI and perhaps overutilizing procedures.
Absolutely. I mean, at its core, in relation to breast screening, the purpose of AI will be, number one, to detect more cancers, and number two, to not call back things that aren't cancers. That's the baseline thing, and you want to detect as many cancers at the same time, not call back anything that's not a cancer. And that's even as a clinician, we balance between the two, and we have guidelines that we adhere to so that we know we're consistent, that there's no variation in the practices between centers and clinicians. Now, there are quite a few breast AI companies, both in Europe and in the USA, and they are all currently publishing their internal research accuracy studies to show the sensitivities and the specificities in relation to how many cancers the AI can detect. At the same time, the specificity, so when it calls something normal, it is normal, or when it calls something back, it's likely to be cancer. These are all things that are being actively looked at in trials right now. Currently, we haven't really adopted, we're not on the path of procurement where we're actually utilizing these AI in clinical practice. I mean, in my own service right now, anything coming that I'm aware of is very much on a research basis, where they're trying to see where this goes in the multiple phases of trials that are happening to see if this does match up to human performance. So I don't think currently we have that risk where anyone is using it, at least within the NHS, for breast screening. Public Health England has not authorized use of it because the research is currently not there, but I know we're getting close to it.
Thank you, Dr. Kumar. I'm going to turn to Dr. Suresh here, and maybe you guys covered this in the ethics piece. I apologize, I missed a portion of that. But I'm just curious: this question raises for me the question about whether it's fair to presume that AI is perfect, and that AI right out of the chute, we're not going to have any more mistakes. We're not going to do any more unnecessary treatments. AI, by its definition, from my understanding, is essentially it's a continuous learning system and a continual learning process where more data informs better decisions. So Dr. Suresh, can you speak to that a little bit? Is it fair to think that,
Sure.
that AI med should be a do-all, end-all from day one?
Yeah, I think it's very fair to presume that AI is not perfect. We can certainly start with that approach, and there are fairly decent AI tools which are not learning health systems. They are static, and especially something like a COVID pandemic, which has changed some of our patient demographic, or patterns of usage, etc. If those are not inputted back into any system, that's not going to help us that much. Going back to what Anthony showed earlier, I'm going to use that as an example to answer your question, Matt. If it can serve as an augmented tool or an assisted tool, then the buy-in from the clinicians and the actual value the providers and the patients will get, I think will be huge. So to look at it without any bias, we treat it as a traditional research tool. What's the sensitivity? What's the accuracy? What's the likelihood ratio? So we're going to ask those kind of questions. I certainly do, putting on my administrator hat as well as physician hat. And if I'm convinced enough to trial it, even as a proof of concept, it doesn't have to be a full-blooded trial, then we can see how good that is. And if it's a truly learning health system, which is going to take every false negative, every false positive into account and refine the accuracy of it, then we got a case. But there is certainly a school of thought that it is much closer to imperfection as opposed to perfection. Thanks.
Thank you, Dr. Suresh. Dr. Fisher, so having heard that, and you know, your point earlier was that there's a significant human element to this, and that if the buy-in's not there, and if the ease of use isn't there, it creates challenges. Hearing this now, knowing that it's an imperfect tool, and that really a big part of what we potentially need to do in the cultural change element of this is to have people understand that and accept that. Can you talk about maybe some challenges either you've had or that you see, or how we can perhaps get more folks on board with the idea that AI ultimately is a good thing, even though it's probably going to take some significant investment on the front end?
Yeah, I think I'd like to just say a little bit more perhaps about research first, because I think we started there, and I think that's really important. I think the danger in all of this is that I have responsibilities in my organization for both on the innovation side and on the research side. And although they're frequently lumped together, it's very interesting to see how different they actually are, and the extent to which people that are involved in one frequently understand very little about the other. And I think one of the risks that we face at the moment is that artificial intelligence in all its forms, and of course it's a very variable feast, it is very much perceived at the moment under the innovation side of things. And that brings a certain sort of very dynamic culture, which is exciting, but it also brings a culture of just get it out there and, you know, prove it works sort of thing. And that, of course, is a danger, particularly in healthcare, because if you cause a real disaster, then you're going to set the whole cause back a very long time. Actually, I think there's loads and loads of opportunity for pragmatic research in this, where you can look at simple, clinically relevant outcomes. You don't need to have fully randomized, double-blind trials in order to do this meaningfully if you're careful in picking both your outcomes and also at least blinding the assessment process. You know, you can look at things like cluster randomization in different institutions or different wards within institutions and so forth. And, you know, I'm very interested in the design of being able to do that. And I think it's really important we push that, because I think, coming back to your question that you asked me, unless we could present people with credible evidence, then we're going to have major barriers to adoption, particularly when you consider all the other human factors that I talked about earlier. I think the usability and so forth is important, but I think related to this, I think the issues of again, I come back to trust, and now evidence is another part of trust, I think is a real critical factor in adoption. And then again, I think it's very important to look at what you're actually dealing with. I mean, when I have my clinical safety hat on, I'm just trying to develop a framework for thinking about what I should say in terms of different potential artificial intelligence systems. And the concept that I'm coming to is that I think you really need to have a sort of a risk assessment procedure that's based on a spectrum. And that spectrum starts at one end with relatively simple and highly transparent systems, you know, which things like may simply be protocol-driven decision support systems that rely on fixed guidelines, which have been developed by humans. And for instance, we've deployed a coronavirus system that's exactly like that. And that's relatively easy to assess. And basically, it just sticks the guidance that already exists and is developed by humans in front of the clinician's nose. And that runs right through to the highly opaque deep learning systems, which even, you know, in principle, you will never know how the system took that decision. And the sorts of considerations that you need to apply in terms of clinical safety and standard of proof is quite different at those different ends of the spectrum. And I think it's very important that we have that kind of risk assessment notion, and that our clients, which will be both patients and other professionals, understand how that's applied. So I think those are the things that kind of interest me at the moment. And although, you know, I'll be honest with you, we're at a very early stage in development of these things, and the things that we have deployed are very much at the left-hand end of that spectrum as I've just described. I think in terms of a way forward, that sort of risk-based approach and understanding of how systems are very, very different at one end of what we call AI to the other end is going to be critical in actually getting acceptance.
So I'm going to do a quick recap because I think I've heard several kind of themes here. I always like to try and figure out what the nuggets are, and then we're going to come back to the panelists for just a second. So I've heard a couple things. One is that obviously human acceptance of AI and the AI work that we do is extremely important. Dr. Kumar talked about the importance of creating structure and having the right people in the room as a part of an AI I wouldn't call it governance, but perhaps planning and strategy process, maybe ultimately governance. We talked about time being the biggest human capital that's involved here, and if we can save people time and effort, that is really where we get some of the acceptance and the bang for the buck. And then we just now heard about the idea of doing really a risk assessment and ensuring that we really understand the impact of the kind of work that we're undertaking before we get too far down the road, to ensure, again, that we have a good understanding directionally, even before we get too far down the road, what some of the benefits and some of the risks, some of the rewards, and perhaps some of the negatives are that come about the work that we have going forward. I'm going to shift gears here to Carl. And Carl, one of the things is, let's say that now you've put some of these structures in place. You've done some work within your organization, your large organization, and that you, as the Senior Vice President of Enterprise Information Management, now are ready to roll things out. How do you go about that? I'm sure that you have a situation where you do have a corporate culture and a culture at Novant Health, but I can also imagine that each individual facility has its own different sub or mini culture. How do you translate what you're able to accomplish either in one setting or at the corporate level across the enterprise?
So we do take it very small with 16 hospitals and 600 plus clinics. We look for different places where it's going to go in, because we are not deaf to the fact that this is people on the receiving end of whatever's going to happen, and they have to feel comfortable. It has to fit within their process. We watch human motion very hardcore on this, because if it does not fit into what they're doing, it's not worth it. So this is one where we have very active participation. Actually, the culture and the attitude is very much curious. And as was mentioned before, there's a difference between innovation and research. They are handled very, very separately. So we are very cognizant of things that would be, I'd say, innovative, as opposed to things that we are tepid in the water with. So there's a lot of feedback loops. There are daily stand-ups. We run things in an agile format. And as we run these things out, we look for very small wins, but we want that feedback over a couple weeks, couple months. And then we go back into, what is the success metrics with it? Did it improve the baseline metrics we were trying to measure or not? I mean, because if it's just a minor improvement, is it really worth the disruption to existing pathways and processes that exist? Or if it's a significant difference, we've seen in some of our things a 50% increase in outcomes and efficiencies. Well, then how do we roll it out? Because it's going to be people across a system. And one of the things that we try to do is make it very, very consistent. No matter which hospital you go to, no matter which clinic, everything needs to be consistent so that our outcomes are as good as could possibly be.
Thank you. Dr. Lin, perhaps you can speak a little bit about your experience at Nationwide Children's, and really with the work that you're doing around intersecting research informatics, translational medicine, and clinical informatics. Talk a little bit about how AI is able to impact that in terms of that translational medicine piece and the change or creation of either new protocols or new ways of doing the work. Perhaps you can talk a little bit about process redesign or performance enhancement as a result that you've experienced.
Yes, so on this topic, I see the AI projects largely exist in two different categories. It's a spectrum. On one side of this spectrum, it's more of the AI, like we discussed before, from Carl on design thinking. It's addressing the friction points using robotic process automation, including the marriage of telehealth and AI together. Right now, we are looking into the potential ways to reduce the documentation burden for the physicians. The key idea is, can we utilize AI as we are conducting the telehealth session over the video audio stream? The AI would provide ambient intelligence doing the documentation part. This is an extremely hard problem and probably need multiple years to solve it, but we see a lot of potential going into this direction. On the other side of this spectrum is to utilize AI to replace anything used to be, we create an index, a rule of thumb. We have a very good experience on utilizing AI to replace, in the pediatric domain, there is a so-called PUSE score that's being used by many healthcare systems to find out which kid is going to rapidly deteriorate before transfer to the ICU. It's for a PUSE score, it's just a score. You add up a few things together. If the score is above 5, you say, oh, this patient, we need to carefully watch this patient. But why? Why we add up these few points together? Why even if this happen, you give it 1 point? Those are all the things. It's pre-AI age. If we have paper and pencil, it's easy to do. But nowadays, we have got data at our own hand. And if we introduce AI to replace those kind of things, we have shown it's going to be really powerful. The same is true for population management. When we have our own accountable care organization. And when we pick up who are the asthma patients need care coordination, because care coordination is kind of a scarce resource. To determine that, we used to have some kind of a rule. Again, it's based on a point system. So we replace this with the data collected over time, and we found that those kind of projects, AI projects, it tend to be relatively easy to do in terms of research. We tend to do a research grant for 5 years, make a very hard problem. For this kind of problem, as long as data is in place, usually it's a 3 to 6 months project from the beginning to the end. So this is really the power of continue to be a learning healthcare system. We can harvest the benefit of AI out of it.
Thank you, Dr. Lin. I think we're at time. I was going to ask John to make a final comment, but I think we've got comments now and some examples of great impact of AI in clinical setting. John was able to provide some feedback about experience, and Carl as well, with experience of great AI impact in even some non-clinical or other operational issues. And I guess we're out of time, so I'm going to turn it back over to Anthony. And thank you all for your great feedback and information. Thank you.
Thank you, Matt. I think only a CEO has the mindset to run a session like this on time, structured, and everyone has an equal say, right, Matt? So, but I do want to just come back to John, because I think he was patiently waiting. So, John, do you want to start this final open forum with the comments that you were going to make in the last session, and we'll wrap up in about 15, 20 minutes. Go ahead,
no,
John.
it's fine. I mean, honestly, everyone has, given amazing comments. I mean, I would say that we're much earlier, and so it was amazing to see what Carl has developed, because in fact, I want to taking some serious notes of where Carl's at in terms of their process, because we're building that today and trying to build that governance and those stand-ups. And I think, well, I don't know how many healthcare systems are that far along but that's seriously impressive. I mean, for us, we've been a little bit diffuse, which is good and bad in terms of the things that we've attacked. I think what we heard before is a lot of focus on sort of machine learning algorithms. I'll just mention that, for us, we sort of diversified a little bit in terms of some of our AI efforts to sort of include things like voice-based assistance. And so the ability to sort of have flexible understanding and interpretation of human voice, both to serve the patient in the bedroom. We've implemented that for our patients. And in fact, we're now in a big partnership with Nuance around voice-assisted EMR and capturing the conversations between physician and patient. So from our perspective, a big role of AI and some of these sort of ancillary technologies is all going to be about reducing the physician burden in documentation. And so, I know we didn't have too much time to touch into that. But that's a big priority. And then the last one being where I think there's still we're just starting to scratch the surface is in computer vision. I think in my view, because telemedicine has taken such a hold, it actually opens up all sorts of new opportunities in AI, because now you have a permanent video feed of a patient. So the opportunities to get mood and interpret facial biomarkers is changed. So actually, I think the telemedicine relationship with the patient can actually improve our ability to identify and sort of treat our patients. So I'm very excited to sort of see what the next year or two bring because of this AI telemedicine combo that we're going to see. So leave it at that.
Yeah, thank you, John. And if I could just ask the speakers from today, the faculty, just turn your cameras back on and your mics back on. So we're going to have a quick wrap-up session here with an open forum, sort of a free-for-all. Is usually one of the most popular sessions when we had live events. So just a few thoughts from me listening to all of you throughout the day. I do think sometimes I'm in an awkward position of defending the machines a little bit. I feel like we're kind of hard on the machine sometimes, maybe the expectation is that they should be perfect or near perfect. And yet we're very accepting of clinicians that make lots of mistakes, obviously not intentional, but just the frailty of humans making diagnoses, and we need to be a little bit more fair. And one of the most insightful comments I had or talked about in the last year or so was we often talk about being concerned with autonomous AI tools making mistakes and making perhaps even a fatal mistake. But we rarely talk about the lives lost when AI is not around. And I think this pandemic, for me, has been very personal and very profound in terms of just thinking about my patients out there who are, because of one deficiency or another, are going to have trouble getting back into the healthcare system. And we don't have a smart, automated way of prioritizing and getting patients in. And every hospital sees this. They're really, really struggling and not having enough automation and prioritization built into the healthcare system, so that when a catastrophic event like this hits, it's particularly detrimental to the patients and the families. There's a lot of collateral damage. They're already seeing non-COVID deaths going way up, and at least in the cardiovascular disease category, and probably others too. Just not having the automation and backup that AI should be able to handle, hopefully, for the future. And I think when we talk about ethics, and I love the discussion about the ethics in the last session, I think what we're really doing is redefining ourselves and learn about ourselves, because there was a lot of unintentional bias that we didn't realize until we had to set it into an algorithm form. And I think we'll continue to learn about that. So what do we feel about our relationship with machines, and how's that going to change in the future? So it's an open question to anybody. Anybody?
So one of the things that I've seen, especially as you look at the risk stratification of patients and who's most at risk as we switched in March to where we are today, and just all of the things that are going on, is there's a lot of data literacy that needs to be brought to bear on what things mean, and also how to understand and interpret this stuff that's gone on. Our teams have spent a tremendous amount of time actually working with people to teach them what the information means. And for them to teach us a lot of the decisions that they would make given what they now understand. So it's been, I think, probably the fastest growth for digital and remote, but it's also been the fastest learning for all of the teams around. The non-clinical teams to learn as much clinical, and for the clinical teams to learn as much about all the technical systems, and also Epic. Oh, wow, I didn't know when I put it in there, or whatever EHR you're working with, I didn't realize that was a consequence. So it's actually, I think a lot of growth has happened around this, but I think it's also touched on a much more, we need to be very cautious with the information and the data that we choose to use.
Yeah, that reminds me, Carl, of the very prestigious journals having to redact papers just because we weren't careful about just looking at the basics of data and the integrity of data. So I think that was such a telling tale in terms of just all of us needing to get educated on data, integrity of data, and how we interpret data. So that was just such a wake-up call for all of us, right? And these are very, very prestigious journals that made that mistake. So, and I think that, yeah, go ahead, Suresh.
No, just along similar lines, a big takeaway, I think, from the ethics session was, like today, I'm sure we are better off on the practical application of AI. We have use case scenarios, we know what the ROI is, we have great success stories today compared to, let's say, 10 years ago. But today compared to 2 years ago, I'm not too sure. And the reason for that is, I think Tom Lowry pointed out that article about disparities, and so much literature has come out in the last 2 years as to not the downsides of AI, but just to make sure that it's relevant with the times, and looks at systemic racism and things like that. And this is not a bad thing. AI is just not going to linearly go up like this. It's going to be a little bit of ups and downs. So this may be a good time to pause and make sure the actual technical folks and the scientists look at society as a whole, and the AI models don't just come out of, I read this recently, just 3 institutions accounted for 80% of AI literature, I think, UCSF, Stanford, and MIT. I'm not sure whether that's good. Is it representative of everything? So it's probably time for a pause, a good pause, make sure everybody benefits from this. And that's the takeaway I'm taking from the ethics session.
Anthony, I think that when new technology is introduced, it's often best to introduce it into low stakes decisions. And that's one of the reasons why it's useful in administrative areas. Mm-hmm. So for instance, one of the members of our board of directors is involved with using natural language processing to automate cancer registries. And obviously that decreases the number of FTEs required to input data, and these folks can use their skills in a more high-touch fashion, but also by identifying neoplasia as soon as it's in a pathology report, they've been able to accelerate the time between diagnosis and treatment of cancer by 2 weeks in a large group of patients. And that not only, that's a great patient satisfier. Yeah. And even from a financial point of view, it prevents leakage of patients outside the institution, because patients and families get fed up when they feel like their care is being delayed. So a navigator can accelerate their care, and that's a perfect use, and it's a low stakes use. And then as this becomes perfected, we can introduce AI into more high stakes decisions.
I think I would personally disagree with that a little bit in terms of, I think we do need that North Star, that cure for cancer vision. At the same time, take care of all the, as Mike Fisher said earlier, the prosaic projects that really can be done pretty well. Because I think I'm just afraid that if we regress to just sort of the automation of things, then we're going to lose that 20-year vision, which I think is really key. I think we need to have a balance of both, and I think that's what I've gotten away from today. It's just the balance of everything, balance between humans and machines, balance between the big idea and then the getting the mundane things done much better than we are doing now. And I think this pandemic has really, really magnified all the deficiencies we have in the healthcare system. So while we are finishing up, I want to just borrow John because he is one of the renowned experts in this area. So what are we expecting in the next 6 to 12 months? Is there a better handle on what to expect? And is AI going to be part of our resource allocation strategies, or is it just, I personally, I'm not losing faith in data science, but I just think, as I said to my friend earlier today, we can't data science our way out of a complex situation like a pandemic very easily, just because human behavior is so unpredictable. But what are you seeing, John? Do you think in 6 to 12 months we'll be hopefully recovering, or do you see this as an ongoing big wave, especially in the US?
Yeah, unfortunately, I mean, it's challenging based on what we're seeing now and the concerns about where the vaccine is going to take us, and even the uptake of even an approved vaccine is not optimistic. And so, it keeps pushing our timeline further and further. A not super effective vaccine that doesn't have a lot of coverage is going to mean that we're living in this sort of masked up social distance world for a good sort of more than 6 months, I would predict. I mean, I kept saying April, May we'd be sort of out on the other side. Now I'm like end of next summer. It's sort of it's unfortunate that we're seeing this. Of course, it's going to burn out at some point, but the hope around getting sort of that herd immunity number is just it's sort of starting to slip away. I think the AI component, I mean, we've seen really great opportunities around AI and the conversational interfaces. I think there's great role for AI and exposure notification and sort of data mining and getting the right epi data to support decision making. I wouldn't say those have been front and center. I think there's been some good examples, but unfortunately, the heart of controlling this event is some very basic public health, and we can't even get those messages across. Yeah. So, unfortunately, AI is not going to get, well, maybe AI could get someone to put a mask on, but could help figure that out. But, fortunately, we're talking basic evidence-based interventions.
It's hard to change human behavior with AI. I've learned that.
It's possible.
What I say is, I totally agree, John. I say that public health in the war against virus is sort of like your armor, and then the AI might be a weapon, but you certainly need both. But I am very excited to see AlphaFold being able to predict viral proteins from genomic sequence. That's huge. And then designing vaccines now with AI and drug repurposing. So I think there is hope. But I agree with you. I think we'll be in this mode for 6 to 12 months. And a lot of it is our own doing in a way for not having a consistent policy. But we won't go there on the politics on the eve of the first debate. But I do think that, first of all, I'm missing all of you in person tremendously. And I think the human-to-human bond is definitely so critical. And I hope you're all doing well. And I just want to close the session by quoting Arundhati Roy, who actually wrote about the pandemic, and I think it's so fitting for us. Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it. So I think we're all in line with the second option, but I truly, truly miss seeing all of you in person. And the huge downside for doing these meetings, it makes me realize I miss all of you more. So, but thank you for being part of a very special day. And I think judging from the responses and emails I'm already getting, they really, our attendees really appreciate the collective wisdom of all of us. And as I always say, all of us are always smarter than the smartest person in the room. So thank you so much, and we'll see you in the near future. Bye-bye, everybody.
Bye-bye, everybody.
Thank you.
Bye. Thank you.